I just learned yesterday, so we started out as CAP, Center for Alcohol Problems, in 1977, and there were three key people. Frederica Alpert, who was a social worker, who was the founder and first executive director. The saintly Dr. Frank LaCroix, who became interested in addiction when he worked in Appalachia and saw alcoholism and went to AA meetings with some of his patients. And Ed Jaffe, who was a businessman, owner of J.J. Corrugated Box Company in Fall River, and he really gave us the money to start. And we started with a 20-bed alcohol detox, a small outpatient program, and a small driver program. We changed our name in about 1985 to Stanley Street Treatment and Resources, and the name change was to reflect the increase in our services and mission. We started becoming more involved in not just alcohol, but other drugs, mental health, women's services especially. So today, as I said, we have a budget of currently $21 million. When I took over the organization as CEO at the end of 1985, we had a budget of about $800,000. Today we employ 390 individuals. We have 40-plus cost centers that Don has to keep track of. These are contracts, these are multiple grants. So when you see the health center, for instance, there are several grants within the health center that we fold into the program, but there are really many cost centers that have to be. We employ psychiatrists, and we have one of our psychiatrists here today, Jeannie Bailey. We have family practitioners, nurses, accountants, psychologists, social workers, community health workers, case managers. We have a nutritionist, we have administrative staff, we have kitchen staff, housekeepers. On the inpatient unit, we have milieu therapists who sort of keep the units running. We have a full range of staff, all types of positions within this organization. And I think it's, it's important to say that we've grown from an agency that really just served the city, and we are now a well-respected global leader in integrated healthcare, primary behavioral health care. We've been doing the integrated care since the 1990s. This is the buzzword, and everybody's trying to become what we are today in 2016, and we've been doing it for a long time. And we are noted for this. We are well respected across the globe. So today we're going to talk, and you'll get to meet a lot of our key employees who are going to talk about the program, what they're doing, and the exciting work that's being done. And I'm going to turn it now over to Pat Enselem, who is our Chief Operating Officer, and she's going to talk about the nuts and bolts of the things that keep us organized.
She had fallen asleep. So I'm grateful to be at the beginning of the day. I think as you start to get tired as the morning goes on, I think you will be energized by the presentations that you're going to hear from the program directors, and especially I think the case panel at the end is really going to be interesting. So I've been here since '87, and a couple of years after Nancy, she hired me as Director of Operations, and we had, as she said, it was under $1 million, one building, no computers. I remember asking our accountant, who had one half-time employee with her, and I was here just a little while, I asked Artie Anderson, how much do we spend on salaries a year? And she said she and Aura would have to work overtime for 2 weeks to tell me. So things have changed a lot, but Artie is still here at 86 and still learning every day and changing and extremely productive. So you know, this is an organization where people stay, and I think one of the reasons we stay is because it is always changing and always challenging us. So, I
Pretty
am,
steep.
help me with this.
Yeah, I see.
Escape. So, I'm going to go over three aspects. I'll give you a snapshot of the regulatory environment in which we operate, an overview of our operational structure that sort of responds to those mandates, and some examples of board role in compliance. So as Nancy, I think you recognize, having been on the board for even a little while, that this is a pretty complex environment in which we work. It's on there, right? Just slow loading. So included in the regulatory environment are program regulations that are tied to licenses. So individual programs like detox, the CSS step down, the methadone clinic, the health center, are all governed by regulations. We have to reapply for our licenses, usually every 3 years, depending on the program. And that involves an extensive application, a day-long site visit, and a number of ways in which they look at, thank you, at compliance. We also, in order to operate in a number of our programs, we administer controlled substances for withdrawal, for example, and also for maintenance in methadone and Suboxone. We need a range of licenses that need to be updated once or twice, some annually, some every couple of years. That would be the Mass Department of Public Health. Bureau of Food and Drugs has to give us a certification for each of those programs. Then we have that, we have to then get the Drug Enforcement Administration, the federal certificate, and for some of these programs, particularly the ones that administer buprenorphine, we need to get a Substance Abuse Mental Health Services Administration also approval. So there's 3 levels. Those all need to be renewed periodically, and we get site visits. We get surprise DEA site visits, usually once every 2 years. We've been really lucky since, 20 years ago, our first one totally shocked us, and we learned a lot from that. So since then, I think we've had really good experiences when the DEA comes in. We're also accredited by the Joint Commission on the Accreditation of Healthcare Organizations. They go by the Joint Commission now because I think they're also accrediting non-healthcare. It's a pretty big organization that really sets the standards for health and human services. So we're accredited by them. They come every 3 years. Their standards encompass safety, facilities, care, staff credentialing, that sort of thing. And we also have to be credentialed by the insurance companies that pay us. So most of them have us re-credentialed to be part of the provider network every couple of years, and they'll ask questions about risk management, safety. They also will come and do a patient chart audit on their patients to make sure that we're up to the best practices in the field. And then we also are governed by patient privacy laws. Now, you've heard of HIPAA, that governs all of healthcare, but because we do substance abuse treatment, we're also governed by much stricter privacy regulations, 42 CFR Section 2, and also our HIV Project Aware is governed by strict requirements that are Massachusetts laws, disclosure of HIV information.
Excuse me, with HIPAA, are there any new appeals to change that slightly so that family members or the patient himself can let someone know that they're going through a problem?
Well, they can always consent. The patient can always consent to let someone know. And I know the issue that you're talking about, and it's one that we've discussed. In fact, I think Sue may mention it when she presents on the detox. Because if we send somebody to the hospital, let's say they And unless they've signed a release, we can't let the family know that they left detox and they went to the hospital, which we realize is, you know, is really not the best care, and can understand how families feel. So they're trying, on the inpatient, they're trying to get people to sign right up front, that authorizing us to let family know should, you know, any emergency situation arise. So I'm not sure, there is a lot of talk at the federal level about 42 CFR, because that's an obstacle to exchanging, coordinating information among providers. It's a stumbling block in the whole federal initiative on interoperability and the HIV regs, which is state. So there are a lot of discussions going on at the federal and state level to change these to sort of fit more the reality of today. So the operational systems that respond to these mandates include performance improvement, safety, risk management, emergency preparedness, staff credentialing and privileging. Performance improvement is really central to everything we do. So all of the functions of the agency incorporate performance improvement. That's just a chart of the committee structure that sort of defines the operations of the organization. When I first came in '87, we first started a quality management team, and the issues that we talked about are the same ones we talked about today: access and engagement. Things have, the field of quality has evolved, and in 2005 we became involved with a national initiative to improve addiction treatment using rapid cycle process improvement. It's called the NIATEX model. We got a Robert Wood Johnson grant to be one of the founding members of this network. The idea was that people are, 1 in 10 people who need substance abuse treatment get it. And the resources available for additional treatment
Could you say that again? 1 in 10 what?
1 in 10 of the people who need substance abuse treatment are getting it.
Wow.
Now, a lot of those people don't think they need it, but the national surveys have resulted in identifying problem drinking that, or substance use that warrants treatment, and 1 in 10 people have recorded that they've gotten it. So we do need more services, and that's just going to be an ongoing problem. But the NIATEX project was to increase admissions, reduce no-show, reduce waits for treatment without increasing resources. And
What does it stand for?
the Network for the Improvement of Addiction Treatment. It's been adopted at the federal level for both mental health and substance abuse, and it's now, they've probably changed the name of it because it's no longer specific to addiction, so it's used in healthcare as well. It's built on the previous concepts in quality management, but it's very effective. It's a quick and sometimes dramatic improvement in performance using these tools.
And can I just say that I was at the UN meeting 2 weeks ago. They've adopted NIATEX as a best practice for international.
So just a few of the things, it uses rapid cycle process improvement. One of the principles they say is get ideas from outside the field, so the hospitality industry, technology, all of that, and understanding the customer, which really is the challenge in quality management, and more with the federal and payment restructuring and payment reform and healthcare reform. The customer is central. We used to get grants, it sort of didn't matter, but once we went to fee-for-service and now with outcomes-based reimbursement, that the outcomes are critical and engagement of patients is critical. So we learned some new tools for how to understand our clients that were pretty powerful. And then these are some of the change projects we've done at STAR. This is one we did earlier using the NIATEX model. It was a long wait for outpatient services, so we created an instant access addiction intensive outpatient program. And you can see how in a fairly short time we increased admissions by 34%, 40%, and then 63%. That was the basis on which we ultimately, several years later, did the open access model for all of our services. And the new thing in healthcare improvement is patient experience design. And I did include in your packets an article from Wired magazine that gives a pretty simple and interesting account of what patient experience design is and why. It's about Planned Parenthood redesigns the patient experience, and it kind of gives you this picture of how you incorporate technology and space design and work process to improve the patient experience. So we have systems for managing risk and improving performance, event reporting, safety, risk management, emergency preparedness. I put in your packets a copy of our event report, and that is an important part of the culture of improvement that we've been trying to build over the years. We encourage people on every level to submit an event report when they're aware of a situation or an incident that they feel could put the agency at risk or compromise quality. And that's the process that we go through. It comes to admin, Kathy logs it in, we have we give it a number, put it in the database, I look at it, might take action right away if we need some kind of intervention. If not, I usually refer it to one of the committees, usually risk management for discussion and some analysis, and then suggestions for change. These are when you look at the event report on page 2, there's the categories and checkbox. These are the categories that we use on the event report. I should let you know that it could look bad in terms of these situations that are occurring. We get about 15 a month, so in the last 16 months, we processed 227 event reports. And they're usually minor things, which is good because we want to know about the minor things because we want to prevent them from getting bigger. The thing that you see at the bottom, client injury illness, is the biggest. That makes sense because that's really the focus of what we do. I would say one thing that we're very acutely aware of and are working on at every level is the risk of overdose. And we have had incidents of people overdosing, fortunately not fatally, on the property. And we have done a number of interventions to reduce the risk of that, to also respond more effectively and quickly. But it's something we need to keep plugging at, and I think everybody is aware of that. Yes?
So I certainly understand the client illness, but how about the client injury? So you're saying that's 70, approximately 72 it looks like?
Right, it's 16 months.
Over a 4-month period?
No, 16 months.
Oh, 16 months.
Yeah, it was.
I see, that's right,
Yeah.
yes,
January,
12 and 4.
And
So,
that's,
so what kinds of injuries are we talking?
maybe they sprained their finger playing volleyball. They tripped going up the stairs. They might have been sent out for a seizure, which if it were really routine seizure related to withdrawal, they probably wouldn't do an event report. But if they had any question about maybe we didn't administer enough of the right withdrawal meds or something like that, they would do an event report so we could discuss it. So they're usually very minor things.
I see, okay.
Pat, I have a question. You mentioned overdoses on site. Is that a result of medication that's being prescribed to the patient?
No. It's more they're waiting to get into treatment. They're afraid they're going to have to wait, so they bring a little to get high. They go in the bathroom, and sometimes they're so afraid of going into withdrawal that they overdose. So we've done a number of things around the facility as well as response to that, and we're also looking at changing our work process to maybe reduce the incidence of that.
And can I say, on the state boards, they're seeing this all across treatment agencies, overdoses, and we are fortunate that we have not had a death, but many other sites have had deaths in their programs.
What consequence would there be if there was one?
We would report it to the state would come down and do an investigation, and they would write up. I know of no agency that has had an overdose death that has been closed, or they just look at the processes and what you have in place, and
that would be devastating for all of us, not to mention the families and the people that know the person. But in terms of being investigated, I think the fact that we have all these systems in place and are very carefully and consistently trying to improve the situation, I think would put us in good stead in any investigation.
Can I ask just one more follow-up? So, to both of you, Is it accurate that all cities in Massachusetts, like Fall River, so the Brockton, Lowell, Holyoke, Springfield, Worcester, the so-called gateway cities, especially the top-tier gateway cities with respect to population and economic issues, do they all have a facility like, I mean, not as good as STAR, but do they all have some treatment facility in the city?
I would say not all of them.
Most do.
Most.
Brockton does, Lowell. I don't think there's one in Lawrence. So most do.
Uh-huh. Okay,
There's not one in New Bedford,
I knew that, yeah.
yeah.
We have a safety program that's pretty robust. The safety committee meets quarterly, and I put in your packets a copy of the minutes from the safety committee so you can see what sorts of things they do. They do inspections of each site. Teams go around and do facilities inspections, and there's a checklist and a timeline for when inspections are due in this calendar year. And while they're doing that, in order to be efficient, they're also quizzing the staff on safety-related questions to see if there are areas where we need to do more staff education. And the safety committee picks a list of questions that they think are ones that they're concerned about staff having the tip of their tongue. So they make a list, and then when they do the site inspections, they randomly pick from that list. They ask the staff, they quiz the staff, and then they keep a record of the responses to see where we need to target education. The risk management is more clinical. Safety committee is more facilities, and risk management is more clinical, and they really get the most of the event reports. It meets monthly. It's chaired by Lifeline's medical director, and they may identify areas where we need to do a change project. We have an emergency preparedness plan that needs to be reviewed annually, which we do in the summer. And when we update it, that includes a hazard vulnerability analysis to see if there's things that happened in the environment, like one year it was the flu pandemic. We did an active shooter drill. We prioritized for a year based on what's happening in the environment. And the board must approve that annually. So the way we've been doing it is that we meet, we update it, we document the changes to the plan, and then we submit those to the board, usually in the fall, for them to review the changes and approve them. If they approve it, we disseminate it to all the staff and remind them that the full plan is available at each location and in admin and on the agency drive in digital format. Policies. This is our policy form, and you notice here that there's a section on regulatory references. That's important because we make more policies than we need. And if you have your liability is so much higher if you have a policy you're not following. So we try to be judicious about creating a policy. Do we really need it, and is it important enough that we're going to monitor and make sure it's followed? So we'll come across an old policy and we'll say, why, what do we have this for? We get rid of it, and then we find out that it was related to some regulation next time we have a site visit. So we try to reference why we created this policy. And the board, annually, we give the board copies of changes and new policies that have happened during the year and have them review them. If the board wants, anybody on the board wants to look at the complete manual, there's certainly, we can certainly do that. Several years ago, there was somebody who wanted to do that. You're certainly welcome to look at them all.
I'm sorry, I keep asking so many questions.
No, that's good.
You keep saying things that intrigue me. Have you been sued for any injury that's taken? So you said we try to follow in order to limit our liability, we are very careful about the policies that we set. Have you been sued for anything that's taken place on the site?
Maybe 15 years ago,
Okay,
someone
that's a
died.
very good record. It's a very good record.
But we've had little stabs at suits. Patients leave and they want some quick money, and they go to a lawyer, and the lawyer says, oh, this person had a piece of tile fall on them, and they think
Can't believe a lawyer would do that.
Sorry to the lawyers in the audience. But you know what? That did happen, but you know what? We went back to our event report database, staff had documented this incident, had documented hearing the client say that he was gonna make some quick money. Another client had witnessed it. So this event report process does help us a lot. So and we have our lawyer get back to them right away, and once they know that we have good documentation, it's not gonna be easy, so they drop it. So
This is the lawyer for the insurance company that we use.
no,
No.
actually, we don't actually start there. We do let the insurance company know, but we have a lawyer that's very highly regarded, very ethical, and he is usually the one we start with. He's up in Boston,
Oh,
and
okay.
he's known us for many, many years. So if he sends a letter to that lawyer, I try not to, I mean, we have to let the insurance company know, but I try not to let them get involved. And then if we did have a case, these lawyers are approved by the insurer to handle it.
Gotcha.
Credentialing and privileging is an important part of risk management. It's where we make sure that the staff are qualified to do what they're doing for our patients. So it involves anybody who's independently licensed. So that's physicians, nurse practitioners, outpatient clinicians. Credentialing means that these are more objective, kind of a quantity screen, really. Do they have their license? Did they actually get the diploma that they said they got? Are they listed on the Office of the Inspector General's database for Medicaid fraud? We have to do that check twice a year on all employees. It's part of a federal requirement. Privileging is where, once they're credentialed, we then say we agree that this person is qualified to, say, see a special population like children, work with addiction, so specialties. And privileging is after the credentialing process. The HR department puts together the privileging packet. Once somebody's been here for a while and they get re-privileged, then it would include things like their performance review, a peer review of their charts, as well as the more quantitative credentialing facts. That is put together in a packet for each person being privileged. It goes to the privileging committee, who reviews it and then recommends to the board whether to re-privilege or not. Any more questions?
Thank you, good job.
It's a 20-bed unit, and we're licensed by the state of Massachusetts to treat substance abusers age 18 and older. We're also accredited by the Joint Commission. This unit admits approximately 1,500 patients a year, 72% male and 28% female. The primary drug is 82% opiates these days, and 12% alcohol, 2% benzodiazepines. There's a lot of polysubstance abuse, so many of the opiate abusers are also using alcohol, benzodiazepines, also a lot of cocaine, which we do not have a detox for cocaine. Our goals of treatment, we want to provide a safe, humane, comfortable detox from the substance or substances of abuse. And we have what I feel are very good protocols that do a good job with this. And we also can adjust the protocols if needed. And we want to provide education on addiction and recovery. And this is accomplished through individual and group sessions. There's group sessions scheduled throughout the day and on topics such as overdose prevention, relapse prevention, they do the 12-step program, so they have a variety of groups that they attend. And we want to prepare client for the next phase of treatment. Because the detox process itself is just getting the drugs out of their system, it's not treating the addiction. So we try to stress that this isn't your treatment for your addiction. You need more. Okay. So our staffing wise, we have a multidisciplinary team. We have the nurse oversees the physical aspects of the withdrawal process, administers medication, and addresses those other health problems that they come in with that are not related to the addiction. Nurse practitioner, we review the protocols, manage some kind of medical issues that come up, We order medications, we can make adjustments to the protocols, and we do the physical exams. I'm there just about every day, and on the weekends, the health center nurse practitioners rotate and take turns coming in, so there's someone there every day. We have counselors, and the counselor performs educational and motivational sessions. They meet with their clients every day, and they assist them in arranging their ongoing treatment. The recovery specialists were formerly called million therapists. The state has titled them recovery specialists, although it is an entry-level position. And they assist the client in the day-to-day activities, and they really monitor the unit for safety. So they're the eyes and ears out there. Okay, so our biggest challenge is the clients leave without completing treatment, more than we want to see. And that goes along with what's going on in their brain, the addiction. There's been changes in the brain, they make impulsive decisions, poor judgment. So it is to be expected, and we try to work with this. So we did try a little change project. We have a lot of new counselors, there's new staff on the unit. The counselor supervisor is relatively new. We work together and we try to have the counselors engage them in the treatment early on. They get a primary counselor, so they're not bouncing from one counselor to another while they're here. We try to keep them with the same person. And they started placing referrals earlier to like halfway houses or other long-term treatment. They used to wait longer, and now they're doing it earlier on. The patients seem to have more of a goal when that's done. They also take them down to the CSS or step-down unit to meet the staff down there. So how we measured this was we compared April from last year to this year, and these are patients that completed the detox program and then went down to the step-down unit. And in 2015, 38% had gone down to the step-down unit, and in 2016, 58% went down. So I think that was quite a big change.
I have a question. The problem with people leaving treatment before it's completed, most of the patients here on their own, or are they court-ordered? Okay.
Some are court-ordered, but it's still voluntary. And we're seeing more and more of the court-ordered people, but they still can leave. You know, sometimes they're walking out the door and they say, oh, I made a mistake, but it's
It's part of the disease, it's the compulsion to use.
What does CSS stand for again?
Clinical
Stabilization service. It's this next level,
The next step
down.
after detox.
Right.
It's downstairs, yep.
One new thing that we're doing, we don't have any data on it, is we're doing follow-up phone calls. So after a person leaves, the counselors are keeping a log of their primary patients, and they're calling them to see how they're doing with their continuation of care, or if they've relapsed, to encourage them back to start the process all over again. And also, as Pat had mentioned, we started, if they are going to leave against advice or early, we encourage them to sit with the counselor and call their next of kin or their emergency contact. And we have called, if we have release, we will call after they leave. But I was at a meeting with some of the other detoxes, and someone said they had a patient that left and overdosed and died, and I believe it was the person's mother. I said, gee, I wish someone had called me. I probably could have talked them into staying, and I said, oh gee, maybe that's something that we should do. So,
Do you have any conclusions about why there's been it's almost a 50% increase, and that's a tremendous accomplishment on those going from ATS to CSS? Anything that you can discern as to why over the last year? What's caused the improvement, Nancy?
Well, I like to think we're doing a better job. We do have a whole new group of counselors that are really serious. They do meet with their patients every day, and so these are people
But part of it is the warm handoff. It's a warm handoff to CSS. You're taking them downstairs from ATS down to meet the staff on CSS while they're still on ATS, right? Wasn't that one of the big changes you made?
And then sometimes we'll keep them an extra day if there's no bed, because in the past, they're told there might not be a bed in it. They're like, why bother, I'll just wait until there's a bed, and they leave treatment. And the other thing is, people that didn't, I think there was some insurance issues that there was if they couldn't go down because of insurance, certain insurances wouldn't pay for it for CSS level of care. And now there's new state laws that the Massachusetts insurances have to.
So last year, we were lucky to get the law through that mandates all insurance companies to pay for at least 7 days of detox and up to 14 days of CSS. And before that, we were fighting with the insurance companies. People didn't know whether they had any chance of staying. They have very little tolerance for anything in the early stages of sobriety, and, you know, and again, their compulsion is to go out and use. So I think by having everybody have the same counselor, we're also offering medication-assisted treatment right on the unit. Warm handoffs to the step-down unit are things that have.
Okay, I'm going to talk about the pregnant addict, and this is on the inpatient units. STAR has been taking pregnant patients long before I was here, and we are known throughout the state that people at the state level at the Bureau of Substance Abuse know that we take more pregnant people than the other detoxes. Other detoxes refer to us. Around 1998 or 1999, the NIH, National Institute of Health, recommended that methadone maintenance is the treatment of choice for pregnant opiate addicts. So we started to look at that, and before that we were just detoxing the pregnant addicts pretty much the same way as we detoxed everyone else. So we started looking at the methadone maintenance recommendation. We still have the woman make the choice. We believe in the woman's right to choose whether it's methadone maintenance or the detox. And we really make sure it's an informed choice. We go over the pros and cons of detox versus methadone maintenance. So we've made progress with that. We also we fine-tune the detox protocol. If they do detox, it's different than the other patients.
When you say detox, that's cold turkey, like this
No,
one?
Detox means taking them off the drug they've been abusing, but we give them medications to control the symptoms. We do pretty well with that. Since 2008, we started collecting data, and we admitted 336 pregnant females, and 83% of those are in for opiates versus the others are usually alcohol or cocaine and some benzodiazepine. The goals of treatment for the pregnant client is we try to make sure they get in within 48 hours of their initial contact, and it's usually sooner. We usually take them right away. And we want to safely detox them from the drug of choice, stabilize on methadone maintenance if appropriate, and we provide case management for, big thing with the case manager is to make sure they're getting their obstetrical care, because we don't provide the obstetrical care here. So the case manager makes the appointments for the person. Our drivers will take, or the CSP workers will take them to their appointments. We don't want them missing any of their prenatal care. And we also provide education regarding the availability of treatment options. Sometimes they do have to stabilize psychiatrically. A lot of, the dual diagnosis unit does take a lot of the pregnant people also. The case manager, we started having a case manager, I think it was around 2006. Joanne Roberts, she does a wonderful job. She sees all the pregnant clients right after admission, usually the day after admission, and she arranges their prenatal care. She assists in arrangements for pregnancy termination if that's what the client is looking for, and she coordinates the care with the primary counselor. And she does the data collection, and she actually calls, she does follow-up calls. She's been doing it for she tries to call it like 3 months post-discharge, 6 months post-discharge. I know a lot of them, she can't find, but we learned a little bit about the outcome of the pregnancies, and in general, they're pretty good outcomes. I don't know if you can see that. This is just the data she's collected by year, 2008 through 2016, and it's the calendar year, so 2016, that's why it's so low. But the red bar is the total number of pregnant clients that were admitted, and the blue bar is the number of the ones that were addicted to opiates, and the other color, whatever, is the number that we got on methadone. There was a few that went to Suboxone that, Subutex, yeah. Okay, so that's how pregnant. And my next topic is medication-assisted therapy. This is the use of medications, and these are used in combination with counseling and behavioral therapies, and it's to provide a whole patient approach to the treatment of substance abuse and addiction. And most of the medications used for med-assisted therapy they work by controlling cravings. So I love to learn about the brain and addiction. So we call this the reward center. It's deep down in the brain, and
Could you go back?
Oh, it's an interactive
Isn't it?
screen.
You touch it.
and,
Touched it.
and
It's responsive, right?
That red thing.
The red, we have a red thing.
Actually,
But it's deep down in the brain. It's where we get our cravings and desires, and that's what makes the addict want to use, and the meds work on that part of the brain. The behavioral therapies and counseling work on the cortex, the outer part of the brain that's more developed in humans. And so using both therapies, behavioral and medication, treats more of the whole brain.
So the VTA is the reward center?
It's the VTA and the nucleus accumbens, basically.
Both reward
Both of them,
centers?
yeah. The dopamine is made in the VTA, and
I
then
see.
when it works in the nucleus accumbens, that's when they get that, really. I have a whole thing on that. The main MAT medications we use is methadone, which is a slow, long-acting opiate, and you get daily dosing in a clinic setting. There's also Suboxone, which is also a long-acting opiate. It's weaker than methadone, and it's office-based, so they can get a prescription for it. Vivitrol or naltrexone is the newest player. Naltrexone is the oral form. It's a pill that they take every day, and Vivitrol is the injectable form, and it's a large injection that they get once a month. And this medication is an opiate antagonist. It blocks the action of opiates, but what this results in is it decreases cravings, and it works for both opiates and alcohol. And there's also Campril and Antabuse. Those are just prescription medicines. We probably won't talk about those. So just how we use it at STAR. So prior to 2010, I think probably about 0 patients were discharged on any kind of med-assisted therapy. And then Vivitrol is a relatively new medicine. It was approved for alcohol dependence in 2006, and then for opiate dependence in 2010. So in those years, we gradually, slowly started using it. There was a lot of barriers, so it was a bit of a process. But before that, it was 0. I'll show you the numbers on the next slide, how many we've been given. We started May 2011. Our first patient was what we call the direct admit to STAR, which means they stayed, instead of detoxing while they were here, they stayed on methadone and then went right to a clinic and to stay on the methadone. Before that, they had to detox, get everything out of their system, leave, and then go to the clinic. So that didn't make sense, so we started doing that. And we do have a case manager that sort of manages all these patients so that they don't get lost in the shuffle. Her name's Mandy. She does a good job. And just the numbers, so we've gone from 0 in 2010 and to 192 in 2014, 251 last year, and so far this year, 129. That's on the Vivitrol. And methadone maintenance, we have so far this year 27. And 2015 was at least 100. We lost about 6 weeks of data when one of the case managers resigned. So I think we've made a big improvement over almost zero to these numbers. That's all. Thank you.
What I'm saying. But the dual diagnosis service is known as DDS or EATS or DDAT. We have several different names. We basically are the unit across the hall from ATS, which is our standard detox unit. And it is the place, in my opinion, where the sickest people in the state get treatment. In order to be on our unit, and it opened in 1999, so this doesn't work, or it doesn't hit the screen because it's like a TV. That's what it is.
Yeah.
Okay. So it opened in 1999 largely as either a diversion from inpatient to keep people from having to go inpatient psychiatrically, or to take people from inpatient. So we were set up as a way of trying to have alternatives that didn't require the higher cost centers of psychiatric inpatient units. The mission has been to serve individuals who have both mental illness, active mental illness, as well as addiction. And that's why I say they're the sickest people in the state, because the people that are schizophrenia or actively psychotic, they get treated in the psychiatric inpatient units, largely staffed by psychiatrists, and there's a whole strata for that. The people who have addiction get treated on ATS. They're pure, quote-unquote, addictions. They get treated in detox centers or outpatients. When you've got both, neither party really wants to handle you, so they create this space in the middle. We're staffed more like the ATS, but we treat people with the same illnesses that the psychiatric hospital has. So it's a challenge. I've been medical director there for, I guess, the last 8 or 10 years, and she says here that I am a member of ASAM. That's true. It's not a requirement for the medical director. It's required.
What is ASAM?
American Society of Addiction Medicine.
Thank you.
And I think what she's also meaning that I'm boarded by ABAM and ASAM, but that's not a requirement. The requirement is that I'm a psychiatrist and that I'm available 24/7 by beeper if there's an issue. I don't have to be on the unit a certain number of hours. I don't have to be, they don't regulate that, but they regulate that there has to be a psychiatrist, an MD with that certification involved. We have a program director, as I said, who's Maggie Carr, and she is a certified nurse specialist, and she's also certified in addiction nursing. Our length of stay at present is 7 to 10 days, and that varies depending on insurers. And with the new regulation, we've had some help from the new regulation in certain areas, and we've been hurt by it in other ways, but we generally provide detoxification when it's needed. Every patient admitted there gets a psychiatric assessment by either Maggie, myself, or another nurse practitioner, someone at a nurse practitioner level. That evaluation includes the appropriateness for medications, the continuation of the medications they came to us on, and we try to encourage the incorporation of medication-assisted therapy for their addiction, in addition to the medications for their psychiatric illness. We see a tremendous amount of polypharmacy, which I'm not keen on, but it's happening all over the state. We try to help people understand the interaction between their mental illness and their addiction and their addiction and their mental illness, and try to get them to often see that if we don't treat both, they're going to fail at both. Just addressing one aspect doesn't really take care of the other. And there's some pretty good data with several studies that have shown that if you really get people undepressed, they still keep drinking. If you get them to stop drinking, they may stop drinking, but they're still going to look depressed. So that, we need to try to address the whole picture. And we try to help people understand that they need to learn particular self-care skills. People who have bipolar and have substance abuse need to learn how to manage things like their sleep, just like a standard bipolar person would. Our addiction people have trouble with sleep. We try to get them to see that they've been dealt a very difficult hand. It's not an easy card game to play. It really sucks to have both. And they really have to work hard at overcoming the challenges of both. And many times our patients just really don't have the social support or the family support or the ego or the education or the life experience to really pull themselves back up, except very, very slowly. So it's a difficult disease to have, and we do individualize our treatment plan and try to do our best on delivering services that are both trauma-informed, but we also try to use cognitive behavioral challenges and motivational interviewing. So in 2015, we had 469 clients on the unit. Our average length of stay over that year was 15.6, and about 78% of the clients completed our program. We did and were able to transition 50% of them down to CSS, or down to the step-down unit. It's a challenge trying to get people with both psychiatric illnesses and addiction treated in holdings or in even our own step-down level of care, finding halfway houses that will feel comfortable taking them. Often if you've had a suicide attempt within the last 6 months, you're not eligible for a halfway house. So you've got the sickest person who's demonstrated that they need the most treatment, but the treatments that we have aren't staffed in a way that allows them to feel comfortable to take that patient. So we're constantly sending them to a shelter rather than to CSS. And I go, that's horrible, but it is sort of where we are, and it's sort of the treatments that we have. So we do treat pretty much all the mass health plans are part of our reimbursement package, and when we have anybody who has private insurance, we work directly with them. We have a coordinator who is available to help us get people on the unit 24/7 pretty much. Mozzie keeps the place running. And I think that was close to 5 minutes. Yes. I don't think I breathe, but
You did a great job. What percentage of the individuals that come into STAR for detox are dual diagnosis?
Well, if you look at the number, what was our total number of admissions last year? 469 over our total number would be the way I look at that, but
So it's two things. One is, I would say about 90% have dual diagnosis, but what we're talking about on this unit is severe and persistent mental illness. So on the detox unit, we may take someone who needs a detox, is addicted, and is depressed. When we're talking about this person, the severity of the mental illness is so
Right.
much greater.
I assume that. What was the total number of detox? I don't have that.
do you know that off the top of your head, Sue? How many people did they?
1,500
So what-
on ATS.
So that's the third, right? Close
Yeah.
to a third. Wow. And your opinion is that 90% of the 1,500 are suffering from some kind of mental health issue in addition to the addiction issue.
Right.
These 1/3 are more severely mentally ill.
Correct.
Okay.
Or their mental illness at the time is much more active. So
Right.
we can have people that are depressed, but
Right.
they may have just tried to kill themselves last
Right.
week. Or their depression has gotten them hearing voices. So it isn't that you have to have, meet the standard of, just schizophrenia or bipolar to be persistent. The issue is that the mental illness is much more active at the time of this admission.
Unstable.
And unstable is another way to say it. We have a lot of people that come on to ATS who have a history of depression, and they're on Celexa, and the depression isn't really something that they even cite as one of their major things they want to work on. And then we're comfortable having them stay on the standard detox.
So it seems as if the whole organization, from what I've heard in the first hour, is very data and statistic oriented, which I think is wonderful. So how do you determine success for these 469 in 2015? What would be a benchmark for you of relative success? I know it's a hard question, but I have to ask it.
Well, for me, I think a lot of it has to do with continuation in treatment. And that means that I am able to get them to go
The next
downstairs,
step. Yep.
take the next step, or that I help them secure outpatient treatment that is legitimate and is all-encompassing, which will allow them to continue their psychiatric meds, which will allow them to take their buprenorphine or their methadone, and that they continue in treatment. Because I think the rule of success for any of this is our patients do better if and they are alive most often if they are in treatment. People don't do well if they drop out of treatment, and they don't live with these diseases if they drop out of treatment. Retention, retention, retention is the message.
So that's like a huge misconception that I think has to be corrected in the public's mind. I mean, to the average person, the layperson, success is that the addicted individual gets well and they go on to a happy life.
But
But
that's-
your standard is just continuing in treatment, which I think is, I mean, I
These are people that are acutely ill,
Right,
that are now needing services.
right,
Will they need them at the same level 10 years from now?
right,
No, I hope not.
yeah,
But many of the co-occurring, the people who have dual diagnosis, we know that their outcome 10 years later is much worse than if it's someone who just is an opiate addict and or just someone who's addicted to opiates and has the possibility of stopping their alcohol or stopping their Percocets without the dual diagnosis picture. You're going to be able to see many more of those people improve their lives, but it's a chronic relapsing disease. And if you've got two chronically relapsing diseases, it's just going to be harder.
Doctor, isn't it true too though, if you take care of the illness, the addiction pretty much goes away?
I can't say that that's true anymore. I think we're all moving our own knowledge base is teaching us that there's something about the brain that once it's actually been addicted, that it is at very high risk for a re-addiction. And so that's why people who've been away from alcohol for 20 years lose their spouse, go bankrupt, say, well, I'm just going to have a beer, and within 2 weeks they're drinking the same amount they were drinking 25 years later. Their tolerance rapidly reappears. You know, someone who doesn't have an previous addiction might be able to have 1 or 2 drinks and still in a week decide, hey, I'm going to, you know. We know that the brain itself has in some ways been changed, and that way we think of it as a chronic condition. Does it just like all medical illnesses, if you take care of your addiction and you manage and you stay attentive to what your issues are, you're much likely to be able to live a normal, productive, and reintegrate into your family, reintegrate into the workspace, reintegrate into your life, and feel good about who you are. I'm not saying you can't do that. I mean, I see people do that all the time on buprenorphine. I see people do that on methadone. I see people do that on Vivitrol. I see people do that having stepped themselves off of all these medications. So it's possible, but it's not the kind of thing where in 6 months you turn this around. It's very, very rare that someone comes in here once, gets detox, walks out, and never uses it again.
And all the studies show the longer a person is retained in treatment, the better they do, period. No matter what the treatment is, I think.
Right. Yeah.
I'm gonna cut it because we need to move on.
What I'll be able to give you in this 5 minutes is a quick history of the step-down services. I'll answer some who, what, where, when, why, how kind of questions, and then I'll open it up to any further questions. So the CSS originally began as a 16-bed level B, they called it, program back in 2000. It's a post-detox level of care. It served men and women together on the same unit. So since then, we've increased our bed number to 32, and very soon we'll be increasing to 38. We've separated the men and the women, so that way they have less distractions and are able to focus more on their treatment and recovery than each other. The women's unit has 10 beds, and the men's unit has 22 presently. So this is a quick snippet from the Herald News back in 2000 when Sandy DiGaetano opened it. She was my mentor for many years, so just wanted to give a quick nod to her. So some of the services they received back then were individual counseling, group counseling, and case management to set up aftercare for when they get ready to discharge. So the population served. Clients must meet the ASAM, which Dr. Bailey said is the American Society of Addiction Medicine criteria level 3.5. So that means they have to be medically and psychiatrically stable to come to the step-down unit. They have to have a very low potential for withdrawal, but they also have to have some risk factors. So those could be things like legal issues, homelessness, family discord, problems keeping a job, other, social stressors. They also have to have poor impulse control, a history of relapse, and that kind of thing. So, like they used to get back in 2000, right when we first started, they're going to have individual counseling. Every client meets with a primary counselor for a half-hour session every day. They have case management 3 times a week for 30-minute sessions. And what they do with the case managers is set up things like halfway house placement, interviews. They make referral to transitional support services, which is the next step down level of care in the continuum, if they're going to go right from inpatient to residential. They also set up things like intensive outpatient programs, outpatient counseling, psychiatric appointments for providers, anything to get them ready to discharge and go back into society successfully. We also offer medication-assisted treatment, like Sue explained in her presentation earlier. The main forms are Suboxone, Methadone, and Vivitrol. So we also link them to other community-based organizations, and like Sue talked about earlier too, we have the pregnancy case manager on the step-down unit. She follows them from detox or dual diagnosis down to step-down, and then for the next 3 months, 6 months, and so on. Okay, so even despite all these wonderful things that we offer, we still are always trying to improve intention rates and reduce the against staff advice rates of discharge. So a little change project that we've been working on recently is with MP3 players. So the step-down unit received a generous donation, and with that we were able to purchase some MP3 players. We loaded them with AA material, NA material, meditation scripts, guided imagery scripts, different relaxation music, and also we polled the clients and asked them to give us some feedback of just some feel-good songs that no matter where they are, if they listen to it, it puts them in a good mood. So based on their results that they gave us, we also added about 30 feel-good songs to these MP3 players. So the counselors are in charge of lending them out and then getting them back for clients that may be struggling with anxiety or having cravings, urges, thinking about leaving. And our thought was that that's going to help them stay in treatment longer. It's also going to keep them connected to their counselor, because the clients know that MP3 players, they're not cheap, and they want to hold on to them, and it kind of like builds that rapport with them a little more too, I think. So what we found since we've been doing this is that in April 2016, clients who didn't borrow an MP3 player while they were on the unit had about a 68% completion rate and about a 24% against staff advice discharge. And then compared to the clients who did borrow the MP3s while they were on the unit, they completed at 88% and only had a 12% against staff advice discharge. So we were really impressed with those numbers and happy with those results. Another new project that the CSS unit is working on getting rolling very soon is called the Vivitrol Pilot Program. So this is a Bureau of Substance Abuse Services funded grant for 1 year, and the goal is to have clients receive their first Vivitrol injection while they're on the CSS unit, and then have clinical case management follow them for up to a year and track their progress, see if they're getting their shot, because it's a once-monthly shot. So seeing if are they getting it on month 2, are they getting it on month 3, helping them set up that next shot. Because like I said, a lot of our clients are going to halfway houses, which means they can be all over the state. So finding agencies for them to work with in Boston or in Worcester or in Plymouth and so on, and then following them so that way they're connected to a person with their Vivitrol. I think what's going to make this a lot easier for us at STAR compared to some other agencies in the state is we've been doing Vivitrol injections in patients since 2010, like Sue mentioned before. So we already have a really good system in place. Sue has her procedures, and it's a pretty smooth process already. So we're really excited to get this going. The majority of our referrals do come from our inpatient department, ATS, the detox unit and dual diagnosis, like Sue and Dr. Bailey mentioned, about 58% of ATS clients come to CSS, and Dr. Bailey said about 50% of dual diagnosis come to ATS too. Some other referral sources that we have, we call these direct admissions, come from our open access center, or things like the criminal justice system, Section 35 programs, shelters, crisis centers, and then other detoxes in the state. STAR has the court case management system working with drug court, so we get a lot of direct admit referrals from them as well. Okay, so in a nutshell, that's CSS. Does anybody have any questions?
With the growing need for more services, do you find there are any bottlenecks in trying to outsource the patients to a halfway house?
Absolutely, yes. So as you go along the continuum of care, the numbers decrease. So, you know, ATS starts with the highest amount of beds in the state, then CSS it lowers. When you get to TSS, it lowers even more, and then halfway house, it lowers even more. So at that TSS stage is where we find a hard time getting clients placed. So that way there is no break in their treatment for them to get to the ultimate goal, which is the halfway house. And it kind of makes sense too, because the length of stay changes from each level to each level. Like on this level, it ranges from about 10 days to up to 20, 25 days sometimes. But then when they go to that transitional support services, the TSS, they can stay there up to 90 days. And then with the halfway house, it can be 6 months to a year. So
I assume those places are also regulated and funded somehow with...
Poorly, yes. They're regulated but poorly funded.
right, all through the Bureau of Substance Abuse Services, yes.
And we also have a bottleneck with our own patients. I mean, we try to hold on to detox patients after that period of time when there's not a bed available, so.
Right, and like,
We need more CSS beds.
yeah, so we're gonna increase by 6 very soon, and that's gonna help a little bit, but I always have like a waiting list for direct admissions. Right now it's about 6 or 7 clients. And then, you know, I'm constantly getting referrals from other agencies too, because they're experiencing the same thing.
From a facility standpoint, is like DTS and CSS, are they located in the same building, or does the patient need to be like
Yes.
transferred over?
So all these 3 services that were just explained are all in our inpatient building. The ATS and DDS are on the same level, just on opposite sides, and then the step-down unit is on the main floor.
And that's the building across the parking lot?
It is, yep, and then the women are on one side and the men are on the other.
So Vivitrol is supposed to reduce or eliminate cravings. How effective is it? I mean, if someone gets a shot, someone gets a shot, they're not gonna wanna use heroin for the month, or how does that
You know
work?
what, can we save that question,
Okay,
because Dr.
sure.
Bailey is gonna talk about the research, and she has a study looking at Suboxone versus Vivitrol. So she'll talk about that then.
Perfect. All right, thank you all for your time.
Compared to what we just saw, so I apologize for that. So I want to talk a little bit about ARISE. So it's a manual-driven family intervention that was created by Dr. Judith Landau and James Garrett some years ago. And since then, it's really been tested in a number of settings, and including a NIDA clinical trial. So it is evidence-based for families. And really what it is, it's a continuum of care that encourages health and healing for addicted individuals, but also their whole families. So I think this is really a shift in how we see family intervention, because we're looking to get everybody into a place of health, healing, and recovery, you know, whatever that means for that family. And really the philosophy is that if any one person wants to make a change towards recovery, we're going to have to get the whole system to kind of make a shift and to make some changes. Who here is familiar with the TV show Intervention? It's a good show, right? You know, it's very dramatic. The person is sort of ambushed by their loved ones, given an ultimatum saying, you know, there's a plane outside, if you get into it and go into treatment, if you don't, we're kind of going to cut you off, or there's going to be some consequence. So that's really not what we do at all. That's really...
Especially with the plane outside.
Yeah, we don't have a plane. We don't. Are you working on that? You know, intervention, and it definitely has its merits. It's certainly effective in getting people into treatment. But what we find is that it's not helpful in keeping people in treatment, right? The pressure's off and they're like, I gotta go, this is too much for me. So the ARISE model is invitational, right? So the person is actually invited to participate. They're invited to come on in. They are aware of every step of the intervention process, so it's completely transparent. And a lot of people say, well, my son Johnny, he's not gonna come unless we surprise him at home. We really have to ambush him. And I have to say, they often do come because they're like, oh, my whole family is meeting and they're gonna talk about me. I gotta be there, so the curiosity kind of wins over and they do ultimately attend the meetings most of the time. And it's also non-confrontational, so there's no real ultimatum unless there has to be, right? So the level of confrontation kind of gradually increases as people are involved in the program. So if they enter treatment right away, there's no ultimatum, right? There doesn't need to be. So it's actually really empowering because the person gets to say, I decide to go into treatment, because my family's concerned, they're approaching me. So it's really a lot more empowering than to kind of give them an ultimatum at the end of the day. And we work with families over the course of 6 to 12 months. So like I said, Johnson gets people into treatment, but it doesn't keep them there. And we know that relapse is a part of a lot of these journeys towards recovery. So we work with them on different things like relapse prevention, psychoeducation. We're placing referrals for the whole family, ideally to kind of get their own treatment, to get into some self-help. So we really see families go from a place of crisis a lot of the times to a place of healing. And it's designed to use for use with any chronic relapsing disorder. So, we use it for addiction here, but it can be used for just general mental health. It can be used for physical health, right? So folks with, say, diabetes who aren't taking care of themselves, it's effective in kind of all those areas. Okay? Oh, it's my job. So we've been doing ARISE here since 2006. We've had 4 trainings, the most recent being in 2015. I myself was trained in 2011 with a second group. And the trainings involved Dr. Landau herself coming here and doing a 3-day intensive training on, family systems, and she kind of goes addiction in the brain, and she really talks about a lot of things. And you're trained on the model itself, obviously. And we have 34 interventionists who staff the program. Several are here today. Raise your hands. Hi, certified interventionists. And as of just a couple of days ago, when I last checked, we worked with 426 families. So just anecdotally, I've seen networks from 2 to 3 people up to a dozen. So you can kind of extrapolate how many people we've reached if we worked with 426 families. And we get these families from all over. We get them from in-house, maybe inpatient, maybe outpatient clinicians. We get referrals from police, hospitals, other agencies in the court as well. So a lot of families will try to section their loved one, and the court's like, hey, how about we try this other thing first? Because it is less harsh, I guess, in a lot of ways. And we've done this with the help of DPH and BSAS for funding.
Which means?
Well,
Department of Public Health.
Yes,
Bureau of
sorry.
Substance Abuse.
Yeah, Bureau of Substance Abuse Services have helped us out, with funding and trainings and all that sort of thing, because insurance doesn't cover this level of care, because it's not technically treatment, right? It's kind of like pre-treatment, so, we need funding in other ways. So here at STAR, we are statistic and data-driven, right? So in 2007, we checked in on how our interventions were doing. We wanted to know how helpful this was. And we found that 79% of our addicted individuals had entered treatment, which is powerful, but also 55% of them went on to a second level of care, right? So as Nancy said earlier, we know that if they're staying in treatment, that's going to have a good effect on their recovery overall, right? And 74% of them reported periods of sobriety or reduced use. And that's just in the addicted individual themselves. It also has an impact on the whole family. So I'll have family members who say, you know what, I stopped drinking too because I kind of looked at what it was doing to my life, even though I'm not the addicted one. So it really has far-reaching effects.
Is that the 74% of the entire group or of the 79%?
Of the entire group,
Okay.
yes. Yeah. And we also did a study with our frequent flyers. So there are folks who have repeated admissions to detox, right? And maybe they weren't staying, or maybe they were just coming back a couple of weeks later. So we provided 11 of those folks with Arise services. And 80% of them, not only did they finish detox, which maybe they weren't doing before, but they went on to second and even third levels of care. So I think that's really a testament to how family involvement can really encourage this continued treatment. And 55% had not relapsed as of the last time they were contacted. And that's it.
As well as the budget and get approval for the annual application. Let's see. It looks a lot better than what I gave you last night. Okay, so we're home to about 6,000 primary care patients. That number is definitely growing, ongoing. I would say we're on the way to 7,000 in 2016. We have 10 primary care providers, 3 MDs, 2 of them are family docs, 1 of them is a pediatrician, and we have 7 nurse practitioners. Most of them are family NPs. 2 ID doctors who have been with us a long time. They're each here 1 day a week mostly. Some weeks they're not here, but usually 1 day a week on contract. 2 cardiologists who are here from South Coast monthly. Nurse case management for many chronic disease, asthma, COPD, diabetes, hypertension, chronic pain management. We have all 3 forms of medication-assisted treatment, which you've already heard about, Suboxone, Vivitrol, Methadone. We have a psych NP, and we're about to get another one. We also have a social worker that's newly hired with one of our grants. Thank you, Crystal. Does this get bigger? All right, so grant funding, you've heard a lot about this at the monthly board meetings. So we have, this is just the federal grants. We've got other state grants that I think others are going to talk about today, but the core of our existence in terms of funding as a federally qualified health center is the 330 grant. So when people say they're a federally qualified health center and they talk about their grant, it's the 330 grant. It's 330 because that's the section of the law that allows for the funding. So we get about $334,000 a year. We're a sub-grantee, so way back when, Health First and STAR both wanted to apply to be federally qualified health centers and to get this funding. Politically, the Mass League had said if you both apply, neither one will get funded because you're 2 health centers in a population under 100,000. So they said you've got to apply together. One has to be the grantee and one the sub-grantee. So way back when it was Health First as the grantee, we're the sub-grantees, so the federal government sees us as one. If you look on the HRSA website, you would see anything that we're doing listed as Health First because they're the grantee. So we've got P4C as Partners for Care, $500,000 a year annually for 3 years. This is the Bureau of Primary Health Care putting money into HRSA-funded health centers for HIV care. And it's the first time the Bureau of Primary Health Care has done that because usually that's been Ryan White funding at the federal level. So for agencies that don't receive federal direct Ryan White Part C funding, we were eligible. We're one of 6 health centers in Massachusetts to get this funding. Very high level of funding, which is great. However, it is probably time limited. We're hoping they'll extend it past 2018, but I don't think they will. So part of this is rolling out routine HIV testing across the primary care setting so that all patients who get primary care with us have a test of HIV on file. And the other part is strengthening the interdisciplinary care we provide for folks with HIV, which is about 250 patients at the health center. MAT, that should say medication-assisted therapy. So we just received ongoing funding of $379,000 from HRSA. This is part of Obama and the federal commitment to medication-assisted treatment expansion, recognition of the opioid epidemic at a national level, and long-term funding to support this. So this is a 2-year grant, but then it rolls into the base 330 grant. So in essence, it's an ongoing grant. We're very excited about it. Outreach and enrollment, we get funded at about $76,000 a year. That allows us to have people help people apply for health insurance. Not only apply to get it on the front end, but you've got to reapply annually, and a lot of people struggle with that unless they get somebody to support them. I have heard anecdotally about PhDs saying that they're very smart individuals and they can't figure out the Mass Health system or the managed care system. Expanded services, about $100,000 a year for 2 years. That allows us to expand our primary care provider population. We're funding part of Dr. Lauren's salary out of that grant. Patient data, we have 658 new patients so far this year. We're pretty excited about that, so we're on track for, say, 1,400 new patients this year in the health center, 4,300 overall that have had a medical visit so far this year. I think we'll get to 7,000, which is a good number to help us bounce back. 10% diabetes, 22% hypertension. You'll hear about the 1422 grant from Paula later that's aimed at pre-diabetes and hypertension. 265 patients on Suboxone, 100 on Vivitrol. The only limitation to Suboxone is the MD provider cap number. If it weren't for that, the number would probably be at least 600 because it's all about that SAMHSA X number cap that there's a lot of advocacy to try to bump it up from 100 to 200 for providers. 60% of our patients have Mass Health or the managed care organizations, meaning subsidized insurance because they have low incomes. 20% Medicare, 18% commercial, and 2% HSN stands for Health Safety Net, formerly called the Uncompensated Care Pool. It basically means free care. 2015, we had 16,500 medical visits and 48,000 overall visits. That includes mental health and behavioral health supports. 2014 was higher. I've mentioned this to the board, 21,000 medical and 55,000 overall. The reason is simply turnover. We had a huge turnover. We had at least 3 providers leave the primary care practice. During that period of time, we have recruited 6 primary care providers since March 30th of 2015, 5 nurse practitioners and 1 MD, so we're back on the rise. We'll hit 7,000 patients this year. 1,319, so 22% of our patients have a documented substance use disorder in 2015, and the year prior it was 27%. Doesn't mean that more than that don't have a substance use disorder, but that's how many have a documented substance use disorder in the medical record. And this comes from the UDS, the Uniform Data System annual report we give to the feds. So strategic plan, we had a 19 program requirement HRSA training from the Mass League last week. Jim was able to come to represent the board. We'll get more information to the board about the 19 program requirements, but there's 3 or 4 directly related to the function of the board. So strategic plan is one of them. We need to develop a strategic plan, and it needs to be a 1-year short-term plan for the health center, and then a long-term plan which is 3 to 5 years. So that'll have to be on the agenda in the next couple of board meetings. Key considerations as we think about that are Mass Health payment reform. Everything is moving from a fee-for-service system to a capitated per member per month type of payment. That changes. We've had that in the past, but we've been on fee-for-service for quite a while. But it really changes the way you've got to budget and prepare for care. Accountable care organizations are going live October 1st, 2017. South Coast will likely be an accountable care organization. Stewart definitely will be an accountable care organization. And for primary care, we've got to think about, do we join one, do we join both, or do we join neither? And there are implications of all those decisions. So we have a meeting on Monday with Stewart, we have a meeting on Wednesday with BMC HealthNet, and a meeting on Friday with Manat Health Center to hear about their experience with Stewart. South Coast is delaying on us, and they're asking for a meeting in late July, so we're not quite sure what the rationale for that is. We need to grow our number of primary care patients to meet our expected goals that we have with the federal government in combination with Health First. Hours of operation are something we always need to look at. We're going to do an early opening pilot in August. We're currently looking at the methadone, folks on methadone at Lifeline. They're technically our primary care patient, but about 300 of them have not well established their primary care. They either no-showed for the first visit or they haven't kept up with care in the last 18 months. We're looking at the times that they get dosed, and as long as some of them are getting dosed early, we're going to pilot physicals as early as 6:40 a.m. at our 1010 South Main Street site, and we're going to put a dose hold on them so they show up for their methadone dose, and they can't get dosed until they go across the way and get their physical at 6:40. We think it's pretty unique, and we think it'll be popular, but we'll do a month pilot and see what happens. Popular over time, not the beginning. We need to think about succession planning for our medical director. Dr. David Carter is a very popular primary care doc. He's been a great medical director, but he has made it known that he's retiring in July of 2018. So we have him for a little more than 2 years. It would not be acceptable to have a gap in medical director. We can't have it. Our other family doc is Dr. Lauerman, who's further on in his career, likely not a replacement medical director. I don't want to have a situation where we don't have at least 6 months of side-by-side succession planning in that medical director position, so we're going to be working aggressively on that. And retention of staff members, I've had 2 assistant clinic managers in the last 2 years. Completely unacceptable. That's a key position within the health center, and I've got to figure out how to retain people in key positions. So South Coast locally is more competitive in terms of pay, insurance benefit, and retirement matching, and I've lost 2 consecutive assistant clinic managers due to a combination of other agencies that provide better options. So those are things we need to think about as we build the strategic plan. Drug court case management, I'll cover that quickly. Judge at the DA's office as needed, as well as a court clerk. Yeah, weekly drug court sessions on Thursdays. If anybody wants to know more about drug court, I would say go to an open public drug court session. They're at 1 o'clock at New Bedford District Court for the New Bedford Drug Court. They're at 1 o'clock in Fall River District Court for the Fall River Drug Court. So a quick 101, they're high-risk, high-need clients. They're at high risk of reoffending. They're at high risk of failing treatment because they've failed several treatment attempts in the past. And they're high need, which simply means they're dependent on substances. They're not using periodically, they're using with addiction. It's a 5-phase system, 14 months minimum. First phase of drug court would be 2 months minimum. Every other phase after that would be at least 3 months. So the perfect scenario for somebody is they do it in 14 months. That's not usually reality. It's usually 18 to 24 months. NADCP stands for National Association of Drug Court Professionals. They have best practice standards. Both the Fall River and New Bedford drug courts are adhering to those. Bi-weekly urine screens happen throughout the process, so even if somebody's at the end and they're about to graduate, they're still getting bi-weekly urines because you got to monitor that ongoing. It's got to be random, and you got to switch up what you're testing for. The first thing anybody in drug court asks the other drug court clients is what are they testing for and how often? If you never test for spice, if you never test for Suboxone, that's what people are going to be using. They'll get creative and use things like Red Bull and Adderall that you're not going to catch on your urine screens. But if you sense something off, you're going to send them for more comprehensive testing. The frequency of treatment and visits with probation and court case managers is dependent on the phase of treatment that people are in. And there's graduations ongoing as individuals graduate, and then annually there'll be a big drug court graduation to bring everybody together. Sometimes those are in the news with people like Steven Tyler speaking at a drug court graduation. A bunch of famous people do that, usually entertainers. Drug court grants, we've got the Attorney General's grant, $425,000. That's a 2.5-year grant. It ends this December. That's what got us started, and then other grants came in. SAMHSA grant for New Bedford, about $350,000. Court Case Managers Program Evaluation and Data Entry. That ends in September of 2018. SAMHSA grant Fall River, that end date should also say September 2018. So we've got drug court grants well funded until the end of September 2018. We have a peer leader and alumni coordinator position open in Fall River as well. Sustainability planning, every grant-funded program that you hear about needs to think about sustainability. For drug courts, we need that in October 2018, so we're already thinking about it. The Attorney General's Office has periodic behavioral health grants. Next round of those will be announced probably in August. SAMHSA grants are usually demonstration projects, so they're usually time-limited. Occasionally you can get refunded because you can add a new element to your program. Bureau of Justice Assistance gives existing drug courts $200,000 grants over 2 years, so $100,000 a year. Definitely one of the options. And then recovery coaching. That's a new way where people can get certified as recovery coaches, reimbursed from insurances for some of their insurances or BSAS for some of their services. I don't think that would cover the program, but that could help offset if we had a reduction in grant funding. So that's it. Anybody have any questions on health center or drug court? I know we're tight on time.
How many primary care patients do you want the health center to be able to provide for over the next few years? You're at 7,000 now. Did you say you wanted to go to 10?
I'd like to go to 10. I don't see why we wouldn't, because we've got 2 sites and we're not even here late every day. We're not here on Saturdays, and we haven't done the early pilot at 1010 yet.
Okay.
And
So 10's the goal?
10 is the long-term goal, yeah, probably the 3 to 5 year strategic plan goal. What the strongest health centers out there rely on grants the least. They get program revenue from third party, and that's how they sustain themselves. Grants are good, but you want to be sustainable based on your revenue.
Last decade. So it is essentially science in the community, and I think it's important just to take a quick step back to look at what is research and sort of why are we doing it, how is it a little bit different. And so I pulled together some thoughts that I think people might not know. That in fact the research that we do here is protocol driven and it's not treatment. We have to constantly remind ourselves and our clients, because we do have compassionate care and we are taking good care of them, but it's not the same as a treatment unit. So when I say it's protocol driven, that means we actually operate under written documents that tell us how things are to be done, when they're to be done, and if we do something that's not in the protocol, then it's a protocol violation. If we're 5 seconds late on something that should be done at a minute, we have had a protocol violation. So we are sort of mandated in many ways about how we approach the patient as well as what we actually do. All of our work is under the direction of internal institutional review boards, or IRBs. Each protocol is reviewed by an IRB to make sure it meets the ethical standards and it protects patients' rights, and that the kind of research that's being done is in fact meets the standards for human clinical services and human research that the FDA requires, as well as sort of the overall international standards. All of our patients have to be consented. They're not signed up for services as they are an outpatient, but they're consented. We sit down with them before we can even, essentially before we can even check their blood pressure or gather a urine. We have to sit down with them and go over our written consent. They have to understand it. They sign initial every page and sign it. It's witnessed. They get a copy that takes them home. They take home with them. If in fact there's some, if I have time, I mail them out to people and they read them before they come in. In our population, they tend to like it if we read it with them. We've actually most recently created our own PowerPoint for the protocol so that we sit with them and go through the PowerPoint, which our patients like better too. But everyone has to be consented. It's interesting that what is given to them and what happens is based on randomization, not on my clinical judgment. Whether they get Vivitrol or whether they get buprenorphine, whether they get treatment as usual or whether they get linked or whatever the project is, isn't based on what I think is best for them, which is sometimes hard for me as a doctor who thinks she knows what she's doing. It's based on randomization. So it's the computer spits out and tells us what they got and what's going to happen and what the next steps are. Now, I've agreed to execute the protocol, and I believe in what the protocol is trying to determine. And I understand that science can't be biased by my opinions, so I respect the process. But it's different, and you have to make sure your patients understand that, and that your team understands it, and that it's the only way we can sort of be unbiased in our research. So it is not my clinical judgment, it is what the randomization scheme delivers. It's also very interesting that most often, myself as well as the team are blinded to what we're actually giving. And some of our protocols are called double dummy, meaning that the patient is getting an active pill or an active implant, and one or the other of them is inactive, but they're having to take in both of those medications. So that one of them is going to be an active pill with a dummy implant, the next one's going to be an active implant with a placebo or sugar pill. Follow me? So they don't know what they're getting, I don't know what they're getting. And in many ways, and the nurse who's giving the injection has to be blinded. So we don't look, we blindfold the patient, we look away. We have staff members that keep the records that are unblinded, and the rest of us are blinded, as well as the patient. So it's an interesting concept. I had to learn very quickly that instead of generating billable hours, I was trying to generate primary and secondary outcome measures. Meaning that whatever the determining data points were for that protocol needed to be gathered by my team. It didn't, so no longer was I worried about my master bill sheet and whether it was a 90801 or 90804. What I had to worry about was that I was enrolling the right kind of person, that we were sticking to the protocol, and that they were coming back, and that they were doing their appointments and meeting their visits so that we could get the data. So it's a different enterprise for a clinician. It's also very important that we needed to get people back. And I keep saying this as I think it's a model for the next move in medical care. If my research team doesn't get people to come back for their week 1, their week 8, their week 16, their day 185, as some of the people in the back are struggling with, we don't get the data. And if we don't get the data, in some of these protocols, we don't get paid. But in all of the protocols, if we don't get the data, we don't have good science. We are being asked to try to help answer important questions like, does Vivitrol work better than buprenorphine? If we don't do this right, we're giving people and the public answers that are not good answers. And I feel I'm not doing that. And even when we move into the pharmaceutical situations, we're being asked to help the FDA decide whether these medications are legitimate and safe and effective and should be put on the market. That's not a small task in my mind. And we need to take our jobs seriously. And so if we don't get them back and we don't have good data, then we have not really fulfilled our responsibility. That's very different than wondering about if I don't call them and she doesn't come in and I don't really touch base with her, I'm not going to breed more dependency, or a lot of the things that classic clinical care worries about. So in classical clinical care, if someone no-shows, the outpatient clinician has an hour off. Now, if they're paid on productivity, they lost money. If they're paid in salary, they enjoy their hour off. In research, if someone doesn't come in, we don't get the data. We don't get paid. And so, for a host of reasons, my staff tracks people like doghounds. The woman in the back that helps me run this program, Michelle Raposa, will find you. I can tell you, she will find you. She reads the newspaper, she checks the deaths, we check who's been put in prison, we have locators that we've even found out what your favorite bar is, we go to where your Dunkin' Donut is, we will meet you halfway between here and Springfield, we will do whatever we have to do to get our data. And that's a different attitude than the outpatients. Now, if everybody in outpatient thought they were going to save money and get paid better if they got people in for treatment, we'd be doing a lot more of this throughout all of medical care. But it's sort of been finding its home in research because we need to have them and we don't worry about the transference implications. So as I've said, we have different goals in research. We have to recruit people. We have to engage them into our treatment. We don't wait for them to call us. We don't see if our caseload is going to fill up over the next 3 months. We recruit, we put up posters, we give talks, we do whatever we can do. We run ads. Sometimes they're even on the TV if the company's willing to pay for it. We do, as I've tried to emphasize, really try to work on retention, and we see them as lost data, not just no-shows, and we have to really adhere to our protocols. So that's sort of the overall enterprise. How do we get paid for doing this, and which projects do we choose, or which projects choose us? Nancy started working with what's called the NIDA, the National Institute for Drug and Alcohol, is NIDA, and NIDA formed what they call their Clinical Trials Network about 12 to 15 years ago. And it was an effort to locate academic centers that would put around them community treatment centers that would give us access to patients, and also means that NIDA could get their evidence-based treatments into the community, but they could get the community to give them research back. So it was supposed to be a bi-directional notion. We have been very fortunate to be one of the active community treatment centers for Harvard McLean Hospital. And we've worked on these following protocols, and without a pointer, I'm a little lost. But the important thing isn't so much what they were, but we've covered everything from risk reduction to working with adolescents who have been duly diagnosed with ADHD and substance use. We've done a computer-based program, and most recently, and we are continually working on the last two here, the CTN 0051. Those of us in research, we just call it XBOT or 51. We always throw around our own acronyms. The important thing to think about or know about these is that these grants allow us to deliver services to the uninsured in our area, and they allow us to be part of, some very, as we mentioned earlier, I just made one for the board members, I'm sorry. So this is what every time we do a CTN study, we have one of these that gets printed it used to be like once a month, and now it's every week. And it's our clinical trial report, which reports on how we do. And every Monday morning is there to tell us whether we've done well or not. And I just printed it out because I wanted you to get a sense that Stanley Street treatment, the green is the goal. My team will tell you green means good, yellow is worrisome, and we do not want red. And in this report, which is our most recent study, and this is sort of the final version as we've ended the treatment, we are in all green, and we're the only site. These are 8 sites from across the nation. So they range from Florida to Ohio to Arizona. We have national calls every week. This is a big deal, and it's a really big deal that my team has pulled this out. Now we just have to keep those last columns that have to do with retention, we have to keep those green over the next year. So our work isn't done, but the point is when we set our mind to it, we can do a nice job. We are beginning the follow-up to this study in which we're going to be recruiting people from the unit to just see what happens when treatment as usual happens. Because this study, 51, is the one where people were randomized to get either Vivitrol or buprenorphine. And we really haven't got the results yet to answer your question, but the point is that no one's ever done this before. No one has ever, the drug companies don't have to do it to get their medication approved, and there's never been a large multi-site trial in which the 2 medications have actually been compared head-to-head in a randomized way. So that data will be coming out over the next year, so no one knows. I can tell you from our experience of randomizing 81 people that they look very similar. You'll be surprised the number of people that will drop out of Vivitrol. You'll be surprised the number of people that will drop out of buprenorphine. You'll be surprised the people who make it for 6 months and love their medication. So we don't really know, but they look very, very similar. It's not a no-brainer. It's not obvious that everybody who gets Vivitrol is doing so much better than the people that got buprenorphine or vice versa. So the other research we do, we have been involved in writing grants and enrolling and engaging ourselves with very well-known researchers. This money comes to us directly from NIDA and from NIH or NIDA. We have been the recipients of that money. We sort of work as subcontractors with McLean and Brown. We still have an ongoing, this is our biggest R01 grant that Dr. Stein and I have. That's going to be running in through 2017. That too is going to give information that's never been, a question that's never really been asked before. What we're doing is we're linking people on detox into our buprenorphine clinic. And buprenorphine is the medication label name for Suboxone. I'm training myself not to say Suboxone because that's like Kleenex. Rickett Van Kieser was a drug company that just sort of came on the market, and everybody calls the medication by their brand name. Medication's buprenorphine. So there are many people now developing buprenorphine. We are now involved in other studies of different forms of buprenorphine. So the medication is known as buprenorphine. So we're trying to retrain our brain because that's we're used to saying it. But anyway, the people in that study are getting linked from detox. They get medication while they're there. 50% of them get linked to medication and come straight to buprenorphine clinic. 50% don't get linked, and we just monitor them and follow them over 6 months or 185 days to see what happens. And we're going to be looking at how quickly they relapse, who relapses more, and the various questions about offset health outcomes and medical offset numbers. So that will be a very interesting study when we get that information. The other way we've made our living here is we've participated in pharmaceutical trials. They only gave me 4 slides, so I had to squeeze things in. If they let me give you more slides, you could have read it better. But you don't really need to read it because it's just all in code. The important thing is that starting back in 2007, we were one of the first sites for the implantable buprenorphine rods. And that's the product that was just approved like last week. We were a part of every one of their clinical trials, though, so all of these pro ones go down through 2011. I was at the FDA, I testified on behalf of the medication, and we are actively involved in trying to not only get our doctors here. I guess Dr. Carter is actually a trainer for that product. He's in Boston today, training doctors how to insert and remove that. We've been real active in that. The other thing that we're doing, which is a lot of fun, is helping other buprenorphine products come to market so that Suboxone isn't the only one that we have available. So these others are different kinds of different forms of buprenorphine. The thing we're doing now, which is really exciting, is working with these last studies here are injectable buprenorphine. So we have 2 companies that we're working with that are developing an injectable form which will last for 7 days or up to 30 days. And so we've randomized individuals who are actively using into an injectable form, not an oral form. So I think that's going to be a game changer. I think it's going to be the move in the way of the future for treatment, and we've been there from the beginning. So not only do we get to do this, but I throw this up just for you to see that I work hard at trying to get some of this, get my name on these papers. This is Addiction is one of the leading journals in America, and Addiction, that's my name. And the other one that was a big coup that actually started it all was the fact that when the implantable data came out, the woman, I was the only female researcher in that study group, and the lady from the pharmaceutical company put me on the paper. I had like 2 papers in my life back then. Why? She knew I was on the clinical faculty, but she put me on as one of the, I had done the research, but she didn't have to include me. Because that went into JAMA, other people started calling us. They wanted us to do research. And it's sort of opened the doors to all we do. The other thing that we also, in addition to writing papers, is we have some posters we wanted to show you. Posters we wanted to show you.
Well, before we move to the posters, I had a meeting with the Commissioner of Public Health and the head of the Bureau of Substance Abuse.
Come on and be setting yourself up.
Yeah, come set yourself up as I'm talking. I just got an email on my iPhone watch, which my kids gave me, and the commissioner and the bureau chief writes, I'm reaching out to see if it's possible for you to provide us with an overview of the clinical trial that STAR conducted on the new implant. We are excited about this new development and are interested in learning more. It would be great if we could schedule a time to learn from your team and about the study and lessons learned. So the state is now looking to STAR to inform them about whether this drug will go on the state formulary. And because we like it and have had a good result, we will do this. So Jeannie, we need to set up a talk.
Oh, that's fine, that's exciting. But I think that, I think it was Nancy's vision that research was going to be something that was also going to help STAR move forward and be part of the discussion. That's why she brought me here, that's part of why she's kept me here and allowed me to be here. And I brought on board several young people that we use as RAs, research assistants. We've been involved in writing posters. This one was, Meg can tell you a little bit about, it's now actually been in print. So this is turned into a poster, into an article, and it was exhibited down in Atlanta at the...
Baltimore.
Baltimore, that's right. It was in Baltimore. Yes, so it was at the American Addiction, ASAM. So there's an annual meeting, this was a poster.
So we looked at clients who came to our detox facility and went down to step down to get Vivitrol, a Vivitrol shot or a long-term injectable naltrexone. And much like the grant that Indra was talking about, where they're trying to give it to them on the unit, we looked at the people who received the shot on the unit and were referred to our health center here at STAR. We looked back a few years, I think back to 2013, and we found 62 of our clients that received the shot on the unit and then were referred to our health center. We had 56% had received a second shot at our health center, which compared to other data that had been similar, the previous data that had been similar was around 36%. And because we are able to induct them on the unit, bring them to the health center, introduce them to their clients, we really think that that was a big part of why they were able to come back for a second shot. We also followed through the follow-up shots, a second shot, a third shot, a fourth shot, and you can see a decline, which is expected, and it is similar to other treatments such as Suboxone and methadone. But yeah, we were successful.
Yeah. And your conclusion? What was your conclusion?
The conclusion, we had 54.8% successfully received the second injection. We didn't really have any variables. We couldn't predict who was going to come back for that second shot, which unfortunately we wanted to see who would do better. But there's a lot of interest in it, and a lot of clients, a lot of clients are interested in it and integrating it into the health center and just staying on campus and having a whole integrated health system.
So a couple of quick questions. So I recognize the insignias on the right. How about on the left there? I'm just curious about the collaboration.
That's Butler Hospital out of
So
Providence.
STAR, Butler, and Brown. And the other doctors, along with yourself, Dr. Bailey, they're affiliated with Butler or Brown?
Right. Dr. Stein works for Brown and has a lab in Butler Hospital.
Yeah.
Then Bradley Anderson works at Butler and he's a statistician.
Yeah.
The rest of us, I'm Megan Reese, that's
I see.
Jessica Flory, and over here is my contact.
We had originally had these on the wall in the boardroom so that you could view them, and then I realized when I sat down in here, it's like, wait, the posters are in the other room and you guys are here, so we turned into human.
We actually will be putting them right back up as soon as we walk out of here, so if you want to take a closer look at it.
I'd love to. And how long did the trial take?
We did a retrospective medical review, so we looked back from 2013 to, March 2013 to August 2015. So we looked at those clients that we were able to see, looking back, who got the shot on the unit and who were able to go to the STAR Health Center.
And scientifically, that approximately 2-year period, how was that evaluated, 2 years?
So I think
Results and conclusions.
this is significant that a continuum of care improves retention and treatment. And we are one of the only ones in the country that has this large continuum of care where they can get it on the inpatient and we can continue to treat them. And so it's about a 20% better rate, right? Than treatment as usual.
I think if you remember, Sue was talking about 2010, no one got Vivitrol at all, and by 2013, 14, and 15, we were beginning to utilize it on the unit for opiate addiction. So a 24-month is a reasonable time frame to look at. And the funding for this is the Stein-Bailey grant that I pointed out, that was an R01. So Dr. Stein and I work together. These 3 people screen every opiate-addicted person that comes to our unit, and it has been since the origination of the study. We're using the screening data to publish other papers and to learn what we can, as we are also trying to gather the information about the long-term results of the people that get linked versus the people that don't. So this was a result of our sort of realizing, hey, we got some data about people that got their first shot, and let's look, and comparatively, we're doing much better than most places. The other poster, so this year, in order to get a poster at a national meeting, you have to write an abstract, submit it months in advance, and the committee then lets you know whether or not you pass the screening or whether you are accepted. And so this year, we submitted 3 to ASAM, got 2 in, and then the 3rd was last week at the opiate addicted poster, at the poster there at the opiate international conference in Boston. So this was our second poster, and I've got, you can see these are, the names across the top are the same, but just different RAs took the different lead on formulating this.
Hello, my name is Micah Conti. I work for Dr. Bailey in the research department, and as she was saying, we do talk to every opiate-dependent individual seeking detox services across the street. So for a 6-month period between May and December of last year, we approached people seeking detox services, and we asked them a series of questions. Among those questions were a set of 10 standardized questions about adverse events that might have happened to them in childhood. So we asked them various questions about abuse, neglect, and household dysfunction. And we were interested in whether or not responses to those questions were in any way related to severity of addiction and negative outcomes of addiction. So the questions that we asked are called the ACE questions, Adverse Childhood Experiences questions, and they were part of a questionnaire that was started back in the late 90s and administered at a primary care facility. And that original study found that positive responses to these questions about abuse, neglect, and dysfunction in childhood, they're correlated to a lot of the leading causes of morbidity and illness in America. So things like hypertension, diabetes, you name it, it's pretty much correlated. So we were just wondering if within an opiate-dependent population, positive responses to these were also correlated to more negative health outcomes. So specifically, we looked at history of overdose, injection drug use, and age of onset of opiate use. And we found that those who reported more adverse events in childhood were also more likely to start using at an earlier age, to have moved on to injection, and to also have had a history of overdose. And that's what some of these graphs show here. So we talked to about 450 people, and you can see that as the number of adverse events that people experience increase, the age of opioid initiation decreases in a predictable manner, going down to the right. As far as injection drug use, you can see that as more bad things happen, there is an increased probability of addiction. And again, the more positive responses to those adverse events, the increased probability of reporting an overdose. It was also interesting looking at this population because, as I mentioned, this initial study was done in a primary care setting with patients who were seeking primary care services as opposed to detox services, and the numbers to that study are available through the CDC, Center for Disease Control. And these light blue bars are the primary care setting, which consisted of about 10,000 people that were polled. And you can see in that setting about 36% of people reported having had no adverse childhood events. In our population, that number decreased to about 15%, whereas in the general population, only 12% experienced 4 or more adverse events, whereas in our population, almost 50% had experienced 4 or more. And so from this, we came to the conclusion that opiate-dependent people seeking detox services have higher rates of adverse childhood experiences, and these adverse experiences are in some way associated to these more negative outcomes of addiction. The reason that these specific questions are important and relevant is just because in other literature they have been shown to have a graded relationship. So that's sort of what we're talking about here, where it's a graded correlation to these negative outcomes. As you go up in number, this also increases in number. In the popular literature, it's some certain types of abuse have been highly focused on, things like sexual abuse in childhood, and certainly those are important, but we want to focus on all of them because it has been shown that they don't just happen in isolation of each other, they happen oftentimes in conjunction with one another, and they do sort of compound and increase that effect. So,
What were the standards for an adverse, it's ACE, right, adverse childhood experience? So, I mean, there's some of the obvious ones like sexual abuse or physical abuse or neglect. How about school-oriented ones, severe bullying, would that be considered one?
so these 10 questions were culled from a few different sources that had to do with, as I said, neglect, abuse, and dysfunction. So they were taken from different clinical sources that had already been being administered, conflict scales and things like that. They were just integrated into one 10-question questionnaire, and those questions asked whether or not a parent or adult in the household swore at you, insulted you, humiliated you, whether or not a parent or another adult pushed, grabbed, shoved, or slapped you, whether someone at least 5 years older had ever touched or fondled you in a sexual way. And then some of them were more subjective feelings, whether or not you felt like no one in your family loved you or that you weren't protected, whether or not you had enough to eat or were properly provided for. And then in household dysfunction, the questions that were called were history of divorce, separation, substance and alcohol abuse in the family as you were growing up.
So wait, before you
History
continue, any of those qualified as an adverse childhood experience?
Any of those
Half
qualified.
of the children in the United States come from a divorced family. So
So,
it seems as if you're, what's that scientific term?
We
You're
didn't form
too
the
broad,
scale.
yeah.
Yeah, we didn't make the scale. We're saying this scale is a standard that is used in many, many, many healthcare settings. And so we didn't make it, so we can't really defend it. But it has been highly correlated with incidents of cardiac disease, hypertension.
But it just seems, I mean,
But
we're getting off track, it just seems, wait a minute, has an adult ever cursed at you? That, I mean, what child hasn't experienced
yeah,
that?
just to address your statement, so, 36% of children hadn't ever experienced
36
that.
hadn't experienced it? They weren't telling you the
Yes.
truth. Come on.
Well, sure, the divorce rate in America is high, but not necessarily is everyone divorced before you are 16 or 18 years old. The question isn't necessarily, did an adult ever swear at you? It's, did they often swear at you? Did they put you down? You might have grown up in a household where someone let slip a word here and there, but they were not often acting in a way that belittled you. And I think that's the difference there. And I think that's why these are sort of a standardized, very specifically worded set of questions.
And I think the difference, is that if it's low level, you see that the incidence of what happens is low level, and as it builds up, it increases. And we can see within our own population that they have very high levels of all of these things, or several of these things, compared to the general population, and that their onset of use is at a younger age, and the severity of this. So this, this is really groundbreaking information that we need to take a step further, if we had the money to study it.
Thank you.
Yeah,
We can read them.
and a round of applause for these. Director of our Lifeline program, which is our methadone maintenance program. Lisa, welcome.
Thank you. Good morning, everyone. I'll just do a little quick overview about Lifeline. So I want to not sure if everyone knows what methadone is. So it's just a synthetic opiate. It's long-lasting. So when patients are titrated on a stable dose, it kind of builds a level in their system, so they're not feeling any withdrawal symptoms. They don't have any cravings to go back out and use opiates of any kind. So the titration period does take about 2 weeks on average, sometimes a little bit longer, depending on what the person's metabolism is, and it also depends on how much use they're doing prior to coming in. For staffing, we obviously have Dr. Martelli, who's our medical director. He's been with us about a year now. We have Robin, who's our clinical director, and then Pat Afonso, who's the nurse manager. So we do have 6 master double clinicians, a KDAC who's been actually with the Lifeline program for about 40 years. We have been part of the STAR system since 2009. We have a per diem nurse practitioner, LPNs, and pretty much the LPNs, what they do is they do a lot of the daily dosing of the patients. They do a lot of the medical assessments, making sure people are safe when they come in to get their dose. We have a client care specialist who does a lot of the monitoring to make sure that the patients do their clinical contacts, so make sure that they get to our intensive outpatient program, make sure that they get to their group and individual counseling appointments as well. Our expediter is kind of like the person at the very beginning of treatment. When the client comes in, kind of gets them acclimated to Lifeline, make them aware of what the responsibilities are for them to be in the program. Also kind of gets them integrated into our primary care center and any psych services and any other services within the STAR system. So at admission, all our patients are required to be part of the health center, which makes it a lot easier for us to manage that patient, whether they're medical care, their psychiatric care, and any other related mental health issues that they have as well. I won't play with them. So for services that we provide, obviously we do the daily dosing of methadone. We are open 7 days a week, and holidays as well. So we dose right now, we start as early as 5:45 in the morning, and that's to accommodate a lot of our working patients. So we have quite a few patients that work. So they need to come in, kind of get the dose, and then go off to work without having to worry about their treatments. We obviously have every new patient that comes in gets a physical from our medical director, make sure that they're assessed, any other medical needs that we need to kind of address and kind of refer them back out into the community if they're already established in the community, and also get them into the Lifeline program as well. Like any other outpatient, we do individual, family, couple counseling as well, and that's ongoing. Right now we do counseling Monday through Friday. We do have some Saturday groups available for some of the working clients. We also have groups in counseling that start as early as 6 a.m. and go as late as 7 p.m. Once again, to kind of accommodate people's different work schedules, school schedules, and any family obligations that they may have throughout the day, so that we're not putting any barriers to access to treatment as well. We do have a satellite of the intensive outpatient program at 1010 South Main. And what we do with that program is any new client coming in to kind of give them more structure into treatment, we do mandate them that they go into the intensive outpatient program. If somebody's a full-time worker and they're not able to make that commitment, we require them to do weekly counseling appointments to kind of get them stable and work on some issues, and then kind of transition them into a regular milieu of individual and group counseling as well. We do a lot of case management, so we do a lot of work with patients who are involved with ECF, the court systems, case management when it comes to refer them to different agencies. Some of our patients might need to travel or guest dose somewhere else in Massachusetts or in the country. So that case manager kind of does a lot of work with making sure that there's no break in service for that patient and lessen their anxiety about keeping their daily dosing as well. Obviously, we're very integrated, being part of STAR for behavioral health and the medical service, so we try to do a lot of work with if a patient's seen at the health center where their provider is, if there's an issue with medication or dosing, to kind of keep that open communication to better treat that patient as a whole versus segmented and not treating the patient entirely. We do randomized toxicology screens, and that's kind of like a little overview of what we test for. The new thing that we have added to our tox screens is just the fentanyl, because just due to the opiate epidemic and then the fact that there's been a lot of fentanyl with the heroin within Massachusetts and Florida, so we wanted to add that to our screen to kind of test patients and address that as an issue on the clinical side as well. I just want a little overview. Right now, our current census as of today was 882 patients. Out of those 800, we probably have a little over 100 patients that are compliant and they get take-home doses, so they don't have to come to the clinic every day. But those are very, like I said, we have a little over 100, so we do have some strict guidelines about who is able to have a take-home dose. So like I said, we have 57% are male, 43% are female. Out of the ethnicity, about 80%, obviously due to the city forest, Portuguese. We do have 2% Hispanic, which we have been seeing an increase in. We do have one of the clinicians who's bilingual, so that's been helping us trying to get that population into treatment and get counseling in their own language as well. and about 1% is African Americans. Kind of looking at length of stay in treatment. Right now we have about 19% that are in treatment 0 to 6 months. Those are new patients coming in. We have about 51%, which is a bulk of our population is in treatment 1 to 3 years, and then we have a little over 30% who've been with us about 3+ years in treatment as well. And we do try to do a lot of work with changing our clinical perspectives of groups and then adding the IOP just to kind of retain people in treatment, because we don't want to be sending people out into the community and having the risk of them relapse and possibly overdose. So we try to change that, try to keep it in treatment and kind of work where they're at about a detox if they're comfortable, or maintenance as well. For payer mix for our clients, 90% of our patients are the managed care organizations or mental health products. We do have about 6% that are commercial, which is actually increasing as the parity laws kind of passed last year. We have been seeing more commercial payers start to pay for methadone services. There are some barriers to some of the commercial plans. And then we are actually down to about 4% that are actually through our DPH Bureau Substance Abuse Grant, that anyone who doesn't have health insurance, or if they actually come into treatment, they don't have health insurance, we actually work with the health center through their healthcare access folks, get them enrolled into an insurance plan. But so in the beginning of treatment, if they don't have coverage and they meet the criteria for the grant, we will actually put them on the grant, and some of those patients pay a weekly sliding scale fee depending on what their income is at that time.
And Lisa, do we know length of stay? Is ours any different than any other methadone program, or are we similar?
We're similar. The average within the state seems to be the 18 to 24 months is where the average patients are. I think some of our focus as we get into changing the clinical model around a little bit is kind of working on the patients in that 0 to 6 months to make sure that they're established in treatment, that they're stabilizing their dose, and get everything else in their lives kind of working in place so that they have a good success rate while they're in treatment at Lifeline. I mean, some of the things that we're looking at to do is obviously with STARS having the grant and opening up the opioid triage center, and that's going to be open up 7 days a week and 7 days a week, 12 hours a day, is trying to figure out how we could work our model a little bit differently so that we could admit patients. Right now we admit patients daily, Monday through Thursday. Our doctor is off on Friday. So trying to figure out how the staff looks like so that if patients come into triage center at 2 o'clock in the afternoon and they're a candidate for outpatient methadone, how to get them into treatment quickly without losing that patient into the community. And we also do a lot of work with our ITS where some patients go through our detox first, get stable, they might stop them on methadone, then they just transition to us completely so that, once again, there's no break in service, and it's a better way to monitor success without having to relapse. We are obviously looking to always ways to figure out how to get patients in treatment quicker. I mean, I think prior to STAR having the open access model, our wait list to get people into treatment was probably 8 to 10 weeks. We are down to patients getting in within as quickly as 24 hours, sometimes same day if the patient, depending on the time the patient comes into the open access center. So just looking for different ways to open up our access to the community. We are looking, and I did put Suboxone, but for buprenorphine, as of April 1st, Mass Health has approved and started to give us rates to do daily Suboxone out of the clinic. So that's something that we have to look at how to implement with our current dosing of methadone, because Suboxone right now is in tablet or film. So monitoring how patients take that medication is a little bit different than the liquid methadone that we use. So we are looking at ways to increase capacity. And how we would use the Suboxone is obviously anyone coming into treatment that's looking for Suboxone, and our health center is full, and we can't put them in another provider in the community. Also, if there's any patients who are struggling a little bit within our own health center that use Suboxone, we can kind of just step into Lifeline, we'll see them daily, increase their clinical work, and then once they're a little more stable, we'll just transition back to their health provider. So that's kind of some of the ways that we'll be using the buprenorphine within the Lifeline program. We are changing our model. Our current model is for open access is clinicians kind of see everyone. There's no appointments and there's no primary caseloads. As our census has grown and obviously the opioid epidemic continues to increase, we're going to go back to primary caseloads so that each clinician can kind of monitor that patient, and if they're struggling, refer them either to increased clinical visits with them or send them back to IOP, and then also working within, either send them to detox if they're still using opiates and need to stabilize a little bit more, then transition them back to us as well. And then we're, like I said, we're looking to definitely expand our IOP capacity within 1010, so that if patients are struggling, trying to get them into go into more intensive outpatient treatment. Our outpatient treatment program, people have to go there at least 3 days a week. It's open 5 days a week, and it's primarily groups, so they're in that setting from 7:45 in the morning till noon time. So they're kind of like a closed group, so it kind of gives them more support, more intensive care to kind of deal with any issues that they're having at that point. And then obviously continue to figure out how to grow Lifeline. Like I said, our census right now is 882. Capacity for that site at this moment, because we do have 3 dosing windows, is no more than 1,000 patients. So looking and working with Nancy to figure out.
And the board to open up a new site to get another 500 patients at the new site. That's what we anticipate. When we build the new building, we'll have 500 methadone patients at the new site on a daily basis.
So I promise, very quick questions. Approximately 900 patients. Are you the only methadone clinic in the city? I should know the answer to that question.
Yeah, but there's another one off of Plymouth Avenue and Pleasant Street, Habit Opco.
Okay,
There's another clinic.
And do you know how many patients they have?
I know last time I spoke to the program director, there were probably about 500, 550 patients.
Okay.
And they're also limited to space in the location that they're in as well.
Of your 900 patients, I would have met, how many are Fall River residents?
I would say at least 95%.
Wow, I never would have expected that answer.
We have a few that come from outskirts, Somerset, Swansea.
Right, so the recovering addicts from the suburbs around Fall River, Somerset, Swansea, Freetown, Westport, where do they go?
Freetown sometimes will come to us. Westport tends to go, there's a couple of clinics in the New Bedford area.
I see.
So depending on transportation, I mean, we've had Westport residents in the past, so if they have a family member or another client that's on the clinic that may be able to give them a ride to the clinic, or if they have their own vehicle.
And Somerset and Swansea, where are they going?
They primarily come to Fall River.
But 95% from,
Yeah.
wow. Wow. And you think it's the same in the other methadone clinic?
I believe so, because that company as well, they also have another site in Taunton, Massachusetts, and Brockton as well, so. And we continue to get calls, we continue to get patients coming into the open access daily. And then the reason that we want to continue to look at how to keep expansion going is, I've been with Lifeline for 20 plus years, and I've been at the time where we've had waiting lists for 3 to 4 months, and you've got family members, clients who are desperately calling to try to get into treatment, who don't do well, either with Suboxone or Vivitrol or with inpatient and when coming to methadone. So it's a hard thing to turn patients away, so we want to be able to admit patients when they're ready for treatment, because that's the time to capture clients coming in, is when they say yes, and it might be Friday at 2 o'clock in the afternoon.
So again, the access and retention and care are the 2 things we focus on.
Anyone else have any questions?
How do we compare to New Bedford? Or to New Bedford?
For census, I do know that they have 2 programs. One of their programs has got, last I checked them probably a couple months ago, is over 700 patients, and the other clinic's got a little under 500 patients.
So it's comparable.
About the same.
But still we're more.
Well, because we have better access, quite frankly.
And that's only methadone at Lifeline, right?
Yes, like I
Yes.
said, we would be implementing the Suboxone or the buprenorphine program. We're looking to come on board as of October, and that's primarily when all the other MCOs and payer sources in the state of Massachusetts will be able to reimburse us for the service.
So the other medications like methadone, Nancy, how many would you say are being treated with those right now in Fall River?
So I think we have close to 300, I don't know in Fall River, I can only count for us.
Right.
We have about 300 in Suboxone and 100 plus on Vivitrol.
Yep, 265 Suboxone, 100 Vivitrol, but you've got other Suboxone prescribers throughout the city, so there's a whole bunch of Fall River residents on Suboxone.
Think about the number you're now talking about with respect to Fall River
population.
adult residents. Unbelievable.
And those are the people in treatment.
Right.
Of course, well, I think the estimate's been about 1,000 or more who are not in treatment.
Right.
I mean, that's staggering. That's why the city is the biggest problem facing the city.
Yep. Thank you, Lisa.
Thanks,
you.
Lisa.
We're located in the inpatient building right across the parking lot, and I'd like to speak to you about the essentials of our program, what we do, some client characteristics, some financial and statistical data as well. So this is just a little illustration we came up with. Much of our program is meeting clients where they're at. We're roughly a 3 to 6 month program, so we follow clients as they go through the continuum of care, which is very fortunate with us. We're able to monitor clients' progression and treatment as they continue on with their path of recovery. So I'm just going to use these as guidelines. It's easy for me to just tell you what we do without reading off of that. So we typically meet with clients the day after they come into treatment. So we'll see what their needs are, what their intentions of doing. Some of them don't know, but we'll work with them. So some of the things we do help with, we help with legal issues. A lot of clients that come in, they have open cases, they have warrants that they're trying to resolve. So we'll work with them, build up a rapport with their probation officer. Sometimes we've spoken to judges face-to-face, let them know they're in compliance to their treatment goals, so on and so forth. We help set them up with medical providers, any type of outpatient aftercare, IOP, primary care, psych, which is a challenge sometimes. We're big on family involvement, and I'd like to say I feel pretty fortunate to speak at this particular time, because now that you've had the opportunity to hear about all the other programs, you can kind of see where we kind of fill in relation to those programs. So we have a lot of clients that work that are part of the ARISE program. Lifeline, we'll make sure we get them to their appointments. We work a lot with drug court clients, court case managers. We do provide transportation, as mentioned, so if we have clients that are part of the Lifeline program or any type of appointments they have, we'll transport them to court. We take clients to meetings all the time with the hope of getting them a sponsor. 24/7 on-call, which I think is imperative in this particular department, because CSP normally works the day shift. We're in the process of expanding that. So we have a 24-hour telephone where clients who are in need, that they're able to call us, and we're able to kind of help them, guide them, try to get them into crisis if they're experiencing crisis at that particular time. Advocacy, as I mentioned, is a big thing we do. So, as mentioned, we work with clients 3 to 6 months on average, possibly more. So our overall goal is to create for them linkages in the community, set them up with a healthy support network, help them build up their support network, because a lot of times clients have minimum social support, so it's up to us to kind of expand on that so they can continue working on their recovery. Some client characteristics, most of them, if not all, are in mass health. Homeless, which is another big thing we find. We help them get housing, help them transition into halfway houses, so on and so forth. A lot of them are newly diagnosed, so they may have one or more mental illnesses or a substance abuse disorder. Minimum social supports, as I mentioned. Minimal income, so another thing we help work on is help set them up with any type of SSDI, cash assistance, food stamps to kind of help build their income up. Legal issues, as mentioned, we work a lot with the court systems, establish a relationship with their probation officer respectively. A lot of them have trauma, which has been discussed before. Medical issues as well, so we help set them up with a primary care doctor, or if they have an existing primary care doctor, we'll help make sure they keep their appointments, which a lot of them have trouble with when they're actively using, so on and so forth. Some client statistics and financial data. Roughly, we sign up, and this is a very ballpark estimate, 25 to 35 eligible clients per week. I say eligible because we have a contract with insurance companies that only certain insurance companies work with the CSP program. Probably 80% of them are eligible. Roughly right now we have 6 full-time caseworkers that carry a caseload of 20 clients, which is a big number. So I would say probably around 100 clients we're working with right now actively. Authorizations typically last 3 months, sometimes more. We've worked with clients in some instances for up to a year. Outpatient referrals have increased, so a lot of times we'll get calls from ABH, Lifeline, Stepping Stone, which is a halfway house located in Fall River, saying the client could utilize CSP services. So we've kind of built up relationship with these insurance companies, and they work with us getting these clients outpatient referrals, which is great. Some financials, as of October of last year, we had a negative profit, and since, as of April, we've significantly expanded our profit of $44,000. That's mostly because we've expanded our staff where, you know, we're getting a lot more client caseloads, so it's helping us generate more revenue. So I'd like to say, I feel like this is a very important program for our client, because a lot of times they come in, you know, a lot of their families don't speak with them, so it's up to us to kind of rebuild those relationships. And like I said, we work with them for an extended period of time, 6 months up to a year maybe. So it's nice because we're allowed to monitor their progress once they complete treatment here and follow them through that continuum of care. So, you know, for example, I've had clients who, I may not work with them anymore, but I build a relationship with them where they can say, hey, I just made a year clean, you know, and it's nice to hear that and to kind of, you know, communicate that information to other staff members who may be wondering how these clients are in their treatment. So it's a great program. We have a great team, and it's expanding, which we're excited about. And if you have any questions, I'd be happy to answer them. Thanks, guys.
Thank you.
You're Director of Ambulatory Behavioral Health, and I'll let you introduce yourself.
Just on putting campus on the Access Center Director.
So, ABH is an umbrella for several different departments. The main component consists of outpatient, which provides intake, individual, family counseling, and group psychoeducation. The staffing comprises of master's level clinicians. Some are licensed independent clinical social workers. We have LMHCs. We have some folks working towards their licensure. Currently, we have 8 full-time clinicians, 1 part-time clinician, and 6 fee-for-service clinicians, 2 who primarily do intakes, and 2 that actually service our high-risk psychiatric patients. We have a psychiatric component, which consists of 1 full-time psychiatrist, Dr. Griffiths, and we just hired a 16-hour psychiatric nurse practitioner who will be beginning with us in July. We have a women's center, which I know Gail's going to present. She's the director of that program. She's going to present a little more specifically on that later in the morning. We also provide driver alcohol education classes for second and first offenders. They're referred by the courts, and they come in and get a 16-week class that they do on the dangers of drunk driving education. And that's actually run by Richard Barnett, who's in LICSW. We have a batterers intervention program, which Dan Buckley will be presenting on. So that makes my job a lot easier up here, because everyone else is going to be presenting for their departments. We have intensive outpatient program at our Stanley Street site, and Lisa did a wonderful job of discussing the IOP that we have down at 1010, that not only services our Lifeline clients, but also any consumer that lives in the south end of the city can actually access that IOP as well. And that was actually as a result of a need that we saw, somewhat that Lisa had spoken to. We know that, you know, research has shown that if we keep people in treatment longer, that they do better. So we actually responded to a need in our Lifeline program to try to keep people and give them the foundation that they need when they're first coming in. But also, we saw that it was an issue for folks with transportation that couldn't make it up to Stanley Street to do the IOP up here. So we opened it up down in the south end for any consumer that lives in that area that wanted to access these services as well. We also have an open access center, and soon to have an opiate urgent care center, which Crystal is going to talk about more in depth in a few minutes. The next slide is basically some stats that we gathered in basically the first quarter of the year to show the amount of patients that we serviced. So as you can see, in January, we serviced over 1,000 individuals in group. That increased in February to 1,128, and then in March to 1,148. We conducted 202 intakes in January, again increasing in February February to 209, and then increasing in March to 219. The biggest increase that we've seen, or the most significant, has been individual sessions. And using the open access philosophy of same-day service, no appointments, we find that people basically need service, they come in and they get service that day. So unlike Dr. Bailey's scenario of the traditional model of counseling where someone didn't show, you had an hour off, in this open access model, our clinicians unfortunately barely have an hour off for lunch because it's pretty much people coming in, they're getting services that day. So as you can see, in January, we serviced 493 individuals. That increased in February to 514 and then in March to 633. So I'm going to hand the floor over to Crystal to talk about our open access model, but I just wanted to kind of hand out, also our group schedule, just so that you can get an idea of what we offer, kind of the variety of different groups that we offer at the times, which are pretty much recovery focused as well as kind of health focused. I know.
Let's get us back on
Let
track.
me finish.
So, before we jump into open access, I just want to share a little bit about my path here at STAR. I've been here almost 15 years, and I've kind of followed almost a continuum of care that patients have followed. I initially started as a counselor on the inpatient unit, did some work as a clinician on the CSS unit while I pursued my master's degree, came over to outpatient counseling and did some of the traditional therapy, had the pleasure of doing some work with the clinical trials, was then moved into the intensive outpatient program, and then in 2013 we introduced the open access program, which was a really different way in terms of delivering our services. Pretty innovative, which I think STAR has always kind of innovative in the way that we do things, and everything is kind of, we kind of gather information from our consumers and see, what do our patients want, how do we best deliver it, and move forward from there. So we moved to an open access model in 2013 as a response to what Dr. Bailey and Robin had spoke to, really high no-show rate, which unfortunately affected, we had some significant revenue loss, and we also had long waiting lists. So this was really a way to offer treatment when patients want it. We all understand how important it is that when people are ready to access treatment, that we're available to give it to them right then in that moment. That can sometimes make the difference of whether someone accesses treatment or not, and we recognize that need. So open access currently operates Monday through Friday between the hours of 7:30 and 11:30 for new patients who are looking to enroll. Patients come in, they have an assessment with a master's level, in most cases independently licensed clinician, who will assess them for different levels of care. Again, we're pretty fortunate, we have a lot of the services here right on campus, so patients are being assessed, their treatment preferences are being considered, along with clinical recommendations of the patient, and then they're either being placed in our inpatient, either our ATS unit, or our dual diagnosis services, our CSS services. They can access outpatient and psychiatry from open access. They also have the ability of enrolling in either of our intensive outpatient programs and our methadone services. Just to give you a small statistic, when just of how our numbers were really affected with the open access, in 2013, prior to the open access, Lifeline census was 486. And 1 year later, we were able to double that number to 863, which I think is pretty impressive. It's almost like we were tackling the opiate epidemic before the Commonwealth recognized that it was an issue. And that's an average of 57 admissions per month. So I think that we were doing some opiate urgent care before we received a grant for it. Here's some we love data. Everything is data driven, and it's important. And I think clinically we certainly appreciate it as well. And these are pre and post scores for e-basis. It's an outcome measure that we use. And what we saw were that our patients were coming in much more acute into the access center, but they also seem to be doing better. And so some of our clinicians, when we switched from the old traditional model to the new open access model, had concerns about, well, gee, how is this going to affect the care that we're giving patients? And this was kind of relieving to see that, yes, they're coming in more acute, but you can see that their improvement was much more significant as well. In March of 2016, STAR was one of the 3 sites across the Commonwealth to be awarded the Opiate Urgent Care Center grant, and we're hoping that we can start this program in August. We are in the process of kind of planning and developing this program, and what we're hoping to see is that there'll be a decrease in overdoses as well as decrease in utilization for the emergency department. A big thing that I think is important is that we're going to extend our hours, so we'll be doing 14-hour days Monday through Friday, and then we'll also be providing some services on the weekend as well, 12-hour days. We'll be working as a triage team, so we'll be treating the patient as a whole, and they'll have a medical assessment, they'll be clinically assessed by a social worker, we'll also be working with CSP, so they have a recovery coach, someone that's really going to help them through the process. We're going to use some interesting technology, which I think is always exciting. We are, like I said, we're in the planning and developing, so we're exploring different things now, but we're looking at a helpline management software to kind of help us with some of these services. We've looked into telemedicine, so we're really looking at how can we do this differently, how can we manage the patients. We have a large catchment area, and so some of these technologies will help us do that better. We're also looking at innovative medication-assisted therapy approaches, and so we'll, with the help of Lifeline, we'll be looking at daily buprenorphine. I'll never say Suboxone again, Dr. Bailey. We're also considering
Never.
never.
Not in your presence, anyway.
Never. I'm like, oh, interesting. So we'll be looking at the daily buprenorphine dosing down at Lifeline. We'll be utilizing the expansion of the MAT grant in the health center, as well as comfort meds. So when patients come to us and they're sick, what can we, in safety, what can we give them that will keep them comfortable and help them come back and access the services that they need. One of the things that one of the trends that we noticed, which was, really important because we recognize that when you're treating the addicted individual, you're treating the entire family, was just the increase of family involvement. So many family members come in with patients, and what's nice, again, is that we have the ARISE program to connect those folks to and provide them with support that they need. So we're hoping to, again, increase our family involvement. And we'll be using some evidence-based tools. One tool in particular is the Continuum, which is an ASAM, American Society of Addiction Medicine. I'm not getting a call on the carpet for what is ASAM. And it's just a guided, structured interview in a decision engine, so that will be helpful to be able to use that. So are there any questions? Of course.
I'm sorry.
No, we welcome it.
Too curious. It seems as if the intakes are holding fairly steady at approximately 200 to 210.
Yes.
Of those 200 to 210, what percentage show up with an opiate issue as opposed to other substances?
That's a great question, and I'm so glad that you asked that, because we actually did, we looked at that because we wanted to consider, we don't want to lose folks who aren't opiate dependent when we roll out the opiate urgent care center, and I want to say that we saw 73%, is that the number? 73% of folks that are coming into the Access Center are opiate-based. That's what services they're coming in for. And I mean, we are fortunate that we have access to the adult detox or Lifeline, the clinical trials, so we're really able to kind of meet that need. But that's a great question. Thank you.
Thank you.
Any other questions?
Preferably that we can answer.
Or one that we can't? We know how to defer those. Okay, great.
With clients, we deal with communities. So our prevention service reach is actually pretty big. We're in Fall River, Dayton, the city of Taunton, and Norton actually just asked us to bring them on, and we built a pretty big coalition out there. These are our funding sources. So our funding sources come through the state or through private funders. We have a bunch of different grants going on. Some of them are regional, some of them are just through different municipalities that we work with. And we have a lot of ongoing efforts. I should preface this by saying our efforts are not just things we pull out of the air. They are through data that we collect from many different sources. We are collecting data through police departments, fire departments, EMS, hospitals, schools. And so we know we have to get in front of this effort. This epidemic is huge. It is a national problem. If we're looking at communities, we are no different than many other communities. So education is critical to get in front of this epidemic. We have, I'm just going to give you a snapshot of some of our efforts, but we are in a couple of different schools here in the city of Fall River. We are in Durfee. Durfee approached us and said, we have these kids that were identified. We don't know what to do with them. We do not have any drug prevention programs. So we went in there as an 8-week pilot project. That turned into an ongoing group that we have there that the students took actually in Brantwood. We had a waiting list. We just graduated kids out of that program, and we'll be starting that back up in the fall. We have a big program with the Resiliency School here in Fall River. They are wrapping up their prevention program, and we're actually doing a big drug summit on the 14th with them. We're graduating some of those kids. Some of those kids will come back next year and train the other kids on drug prevention. And so really getting into the schools is critical. We're here in Fall River. We're replicating this work, remember, in each town that we're going into. We've seen through our data that we had a rise in overdoses in our elderly population. We knew we had to focus on that. We were seeing people present 60, 80, 90 years old with drug overdoses. So we've gone out in all of our communities, to the senior centers, to the high rises. We've done drug take-backs there with them. We've done education on how easy it is to become addicted to some of these pain medications that they're on, how not to share them with family members, the signs and symptoms of addiction. We've had tremendous results with that population. And then we have to do physician training. So we partnered up with Boston School of Medicine. They've done a lot of trainings for physicians in the area. Again, we've done them in all of our communities. Each training brings in about 100 physicians. They get CMEs. It's done by a doctor. We have done local trainings with Sue Sainamore. She's done a lot of trainings on the prescription monitoring program. Our last training brought in about 250 community members about addiction prevention. So, and we're replicating this throughout the communities that we represent. We've actually been asked to help build up other community coalitions. So we're actually going to go to Wareham and Dartmouth to help them build up their coalitions. Other efforts that we have going on, the police came to us and said, we really want to give out resources. We just have cruisers. We don't have a lot of space to give out resources. So we created for them, in 3 different languages, pocket resource guides. They fold out. All our police in our clusters and our EMS has them. So when they show up to an overdose, they are readily available to give to a patient and their families of treatment for them or their family members. We have outreach police teams in Taunton and Norton that we here at STAR are actively involved with. So after an overdose, the police will get a log and they'll go out with a volunteer clinician to a house and offer services where to get resources. Again, when we're talking about prevention, we really have to get in front of the issue and we fight it on 2 different levels. So we have to put infrastructure in place in our communities, which is education in schools, changing the way people think about these prescription drugs that are being prescribed, empowering people to talk to their physicians so we don't have another generation getting addicted. But then secondary prevention is really getting resources into the community, into the people who are suffering and helping them get into treatment. So again, we have our regional opioid trainings. The community needs to see things happen. So we're having all of these things in place. We're having policy changes and education, and the community doesn't see all of these things. So we know the community needs some feel-good things. So we did a color run. We were a little nervous about it. It's the first time we did it. We had over 400 runners come, and it was a drug-free event that the community got involved with. We just had it. It was very successful.
So and I don't know if anybody knows what a color run is, but they get pelted with color
Powder.
dye.
We were a little
As they run
nervous,
through.
but it turned out it was very well attended. We have a very good relationship with the Herald News and the Taunton Gazette. We have a monthly article that goes in each newspaper that really talks about what we're doing in our prevention efforts in the community. We do drug take-backs with the DEA's office once a year, and then we do them locally with our local police departments in our senior centers, our high-rises. We do alcohol compliance checks in all of the communities. A police officer goes out with an underage kid, sees if he can buy alcohol. If he does, he brings the alcohol back to the police. They go in and cite the company. Very interesting. So, and then again, we're mentoring coalitions. So we have a lot of prevention work going on. Too much to talk about in 5 minutes. But that's a snapshot of what we're doing across the Commonwealth. So, any questions?
I do have a question. I don't know if you can answer this. I kind of wish Sam was here because he'd be able to get some insight on it. So on this prevention scheme, we've got an epidemic that's happening. Everyone acknowledges that it's a serious problem. From a prevention standpoint, what's being done with like street level dealers, like kind of solving the problem at the root? I mean, are they out of jail in a couple of months and back on the streets dealing? I mean,
I can tell you that they are picking up. So in our coalition, we have, in each coalition, in each community, we have the vice unit that sits on the coalition. So they'll tell us, and my husband's also an undercover narcotics detective, so I have really good insight on that. But they are arresting people, the big dealers. They're not going after low-level dealers. They're going after the involved with the Mexican drug cartel, the big dealers. So, you know, speaking, do we need tougher drug laws for that, for big-time drug dealers? Of course we do. But they are working on that end, I know that. They're a very active unit in all our departments.
Okay, we need to move on because we are running out of time. Bob, no, I'll pass, you talk.
Oh, thank you. So I'm Bob Hitt. I'm the Program Director of Project Aware. Project Aware oversees integrated counseling and testing for HIV, hepatitis C, syphilis, chlamydia, and gonorrhea, and case management for people with HIV and no longer Hep C. Wrong way. So Project Aware began in 1989 as a response to the HIV crisis, as we were starting to see people in the detox present with AIDS. STAR opened the first HIV counseling and testing site, and today we provide an integrated counseling and testing where we bring people in and we spend 20 minutes to 2 hours with them doing pre-test counseling and education around HIV, hepatitis C, syphilis, chlamydia, and gonorrhea. And then if they are able to test at that time, we test for all of those things. We have an STI clinician, Heather, who is available when someone has symptoms or presents as positive for syphilis, chlamydia, and gonorrhea. We treat both people who are testing positive and their contacts. We work closely with the state field epidemiologists, so sometimes they'll bring someone in and say this is a contact to syphilis and we treat them here. And we also do outreach in the detox at Stepping Stone and the IOP programs. We do 45-minute groups to talk about the benefit of looking at your risk for HIV and hepatitis C while you're accessing help, recovery for the first time. We do integrated testing. We've switched. We don't do any rapid testing any longer. We've switched to what's called the 4th generation, and I'll explain what that is in a minute. We do hepatitis C antibodies. We present education on the basics of each sexually transmitted infection. We make retesting recommendations because one test doesn't really tell you everything. And we do a lot of talk and planning to reduce risk and harm in the future. We demonstrate condom use, we demonstrate bleach kits, we talk about other options than placing yourself at risk for HIV and hepatitis C. And then we offer access to other services, and when someone tests positive, we hopefully transfer the trust they've built up in the counseling and testing staff into the provider who can take them right into service. Oops. This is the 4th generation test, and this is why we use it. In the past, we could only, where
It won't show.
Well, it won't show on there, that's terrible. Who bought that? The blue line is where we used to be able to tell people had antibodies to HIV. So if you came in prior to day 24, we would tell you, you're testing negative, come back in 3 to 6 months and get tested again. Well, now we can tell with the green line that you have actually formed antigen, the virus itself, and that means it's an acute infection. If you're positive for the antigen and negative for the antibody, you have just been infected in the last 2 weeks. And it's incredibly important that you start medication then, because your outcomes down the road are better the earlier you stop medication. So you can see that red line is where we would have told people come back, and then that red line is where they would have been out thinking they were negative or not knowing if they were negative or positive and transmitting HIV and hepatitis C. That's just our testing numbers. We test about 1,000 people. Most of them test for HIV and hepatitis C. A smaller number test for syphilis, chlamydia, and gonorrhea. I gave you a sheet that sums up calendar year 15, which tells you how many of each test. What's important to see in the testing is our hepatitis C positivity rate. Of the people we test for hepatitis C, 26% test positive for hepatitis C. And the other one that is pretty significant is syphilis, because in the 90s they believed they had practically eradicated syphilis, and we have had 10 cases in the calendar year. About 19% of the people who were tested positive for syphilis. Medical case management of PLWHA, that's people living with HIV or AIDS, was initiated in 1994 to provide supportive services to people living with AIDS. It's funded by the Ryan White Care Act. We get a mix of Ryan White Care money funneled through the state and state funds. Caseloads began to grow. We'd have caseworkers working with 50 or 60 people. You really can't manage that number of people, so we moved to a triage system in 1997 that looked at the acuity, the kind of needs that the individual had, and gave them care based on what their needs were. In 1998, we secured HOPWA funding, that's Housing Opportunity for People with AIDS, funding through the City of Providence, and to offer case management for the 6 people of Stepping Stone's Next Step Home program who are HIV positive, and to provide our benefits coordinator. The paperwork involved in maintaining your insurance and your drug coverage is incredible. So the caseworkers were spending all of their time every 6 months redoing this paperwork. So we hired a benefits coordinator to come in and assist them with that. And 19 years later, the state decided the acuity-based system was the best way to go and moved all programs to it. This is simply the algorithm. Somebody comes in, they go to the Access program, they have a full intake and assessment, talk about what they know about HIV, how long they've had it, what their supports are. If they're high functioning and really don't need anything, we simply help them get their medications and check on them every 6 months. Then there are people who usually could do that, but they're in crisis because of the change, due to either the diagnosis or a change in the diagnosis, or they've lost their job, or they're trying to tell people about their status. They would work with a caseworker for 30, 60, or 90 days and then renegotiate based on need at the end of that. And then we do have patients that need ongoing daily, weekly, monthly contact. And it's usually more about the other things in their lives, not HIV. Poverty, mental illness, substance use, all of those. The biggest thing you need to think about here is the hepatitis C. At the end of this month, we will no longer have hepatitis C case management, meaning in calendar year 2015, we treated 48 people in the health center who cleared hepatitis C as a result of that treatment. But the caseworker who does all of the legwork to get the medications in here and the client set up and works with the doctor, the state has redirected those funds back to another program. So Nancy's been talking with the department about how we can increase the capacity, keep the capacity we have, let alone increase it. That's me.
Okay.
Thank you, Bob.
We're not gonna get to the,
What?
we're never gonna get to the, Paula, are you next? Who's next?
I'm next.
Oh, Dan. We're not gonna, we're out of time.
Well, they said they could stay till 12:15. Can we get lunch and bring it in here?
I think what I would like to do is finish up and maybe at the next board meeting have the whole panel, because I don't want to rush the panel. So, Dan? What's everybody doing?
Am I?
Oh,
Good morning. My name is Dan Buckley, and I'm the director of the Intimate Partner Abuse Education Program, formerly known as Batterers Intervention Program. The name is being changed and goes into effect, the new name, July 1st, and it's been changed by the Department of Public Health, who, along with the directors of the program, felt that the term batterer was a little too harsh in dealing with a lot of our clients. What is it? We're a psychoeducational program that is designed to teach clients to use non-controlling, non-abusive behaviors towards their intimate partners and or children. We maintain contact with the victims and or partners associated with the incident that got the people into the program to begin with. Sometimes partners and victims are one and the same. We try to teach them to take responsibility for their actions. That's probably the hardest part of our job. It's usually 85 to 90% of the people saying, she did it, she got me into this program, or he got me into this program. We regularly report to the courts and our DCF, all referral sources really, on the participation in the program, their compliance with the program rules and so forth. Normally in the form of monthly reports, but usually phone calls are frequent with probation. And we finally offer an alternative to jail for first-time offenders who assault their intimate partners and or violate a restraining order. In order to successfully complete the program, clients have to complete a minimum of 80 hours, which we translate into 1 2-hour group a week for 40 weeks. And I say minimally because if we feel, for whatever reason, the client doesn't get it, we'll keep them on. We offer classes mornings, afternoons, and evenings for the benefit of everybody's schedule. The vast majority of our clients are court-ordered. As you can see up there, 80 to 85%. Another roughly 10 to 15% are referred through the Department of Children and Families, and the remainder are either therapists referred or volunteers, but I use the term volunteers loosely, because usually there's some kind of hidden agenda, like the partner has issued them an ultimatum, or they've got a court case coming up and they want to look good in the eyes of the court. We attempt to contact victims and our partners. Again, they can be one and the same. Often lately it's getting more difficult. It's hard for us to do it because we don't know if the perpetrator is living with the victim, so we don't leave messages, we don't send letters, we make a call and hope that the victim will answer. We explain the purpose of the program, limitations of the program, limitations being that just because a man or a woman completes the program doesn't mean that they'll necessarily cease offending. And an important part of contacting the partners is assessing the dangerousness of the perpetrator, particularly if he's living with the victim, and gauge the behavior of the perpetrator. We remain in contact during the entire 40 weeks of the program for the same reasons, seeing if the perpetrator has changed behaviors at all, and making sure that the victim is safe. We terminate them if they reoffend, if they violate a restraining order, if they refuse to accept responsibility for their actions, if they somehow or other violate our program rules and regulations, of which we have many. And insurance does not pay. Insurance considers us, which we are, a psychoeducational program, not a therapeutic one. So the fees are paid entirely by the clients. We have a sliding fee scale that ranges from $15 a week with community service to a top range of $35 a week. No one, as it says, is denied accessibility because of their inability to pay. So we'll take anyone. I'm done.
Thank
So,
you.
Any quick questions? I know we're in a hurry. Thank you.
Thanks, Dan.
We have 2 minutes, Nancy? I'm Paula Bollier. I coordinate two grants. I'm going to try to just go through, summarize my summaries. They're referred to as HIP in 1422. HIP is a Primary and Behavioral Healthcare Integration Grant, which is a SAMHSA grant. And the goal of that is to improve the physical health of individuals that have a serious mental illness. And so we're in the 4th year of that grant. We're going to be ending at the end of this year. We've enrolled over 500 of our clients, all of which have a serious mental illness and a chronic disease or illness. They get a care manager who works with them to try to improve their connection to their primary health care, specialty health care, reduce barriers to improving their health, and also help them with things like housing and family issues that kind of impact their overall health. There's a wellness component to the grant, so we were able to add some wellness services for our clients and also to the open access schedule. We have a very successful 8 a.m. daily walking group that we've done for over 3 years. The regulars have walked over 9,000 miles in that group. We have had tobacco groups, nutrition groups, wellness groups. We do a monthly health event in the wellness room on a lot of different topics that the clients and the staff can come to. We've also, during the grant, had a STAR team for the Fall River Fitness Challenge. Have had 40 to 50 staff and clients each year that have participated in that. They're able to do their weigh-ins and everything here. And we reassess people at every 6 months while they're in the program. We've had very positive overall outcomes in terms of their overall functioning and improved mental health status. We also look at their physical health indicators. And those measures, we've seen the most improvement in blood pressure and their A1C and glucose. Haven't seen too much great improvement in tobacco use and obesity. Definitely improvement, but in terms of people, quitting smoking or no longer having an at-risk BMI, that's been something that we have not had too much success with, and that's been an overall grant issue or problem that there hasn't been too much movement in those two indicators. We did have Massachusetts Blue Cross Blue Shield did a study of the 4 Massachusetts PBHCI grantees, and there's about 180 throughout the country, so there was 4 in Massachusetts at that time. And our site had significant improvement in the client's mental health statuses from baseline to reassessment, and the other sites really didn't show any improvement in that area. So we're really excited about that. And we were very sorry to see that grant end, but I hopefully a lot of the things will kind of continue on, a lot of the groups that we're doing and services. The other grant that I'm involved with is called 1422. It's a state and local actions to prevent hypertension, obesity, stroke, long name, we call it 1422. And that's a CDC funded grant to the Mass Department of Public Health. They funded 4 Massachusetts cities or municipalities, the city of Fall River being one of them. And the cities had to partner with a health center as their clinical partner for the grant, and they chose to work with the Family Health Center at STAR. And it's looking at making changes in both the community of Fall River as a whole and the specific high-risk population of patients at our health center. So what they're really targeting in this grant is patients that have pre-diabetes, better identification and treatment of them, and also patients that have uncontrolled hypertension or have undiagnosed hypertension. And so this, and also folks that have low income, low socioeconomic health disparities. There's two components to the grant. Component one is the city component, component two is the clinical component, and the two components are to be working kind of together on a variety of different interventions. In the component one city part, they're looking at built environment, increased walking groups, walkability, bikeability, adding walking groups into the city for just the population as a whole. They're really focusing their efforts on the new Quikasham River Rail Trail, which will be opening up in the city and having a lot of walking and events and stuff down in that area. Also healthy retail, so looking at going into supermarkets, small markets, food pantries, hospitals, and actually for the hospital piece, we're using our cafeteria in our inpatient basis for the hospital work. The component two is what we're doing in the health center, and so there's a lot of quality improvement efforts, and really looking at the systems, better identifying the patients that are being seen here that have pre-diabetes or undiagnosed, uncontrolled hypertension, different things to kind of make them be serviced more. Adding 3 community health workers that will be part of the team in the health center that will actually be able to work with these patients and kind of connect them to the community resources for better health. They'll be making referrals to the YMCA Diabetes Prevention Program as one of our partners, and also doing that through like an e-referral system, so that we've been doing a lot of work with that and setting up where the providers will actually be able to make a direct referral to the YMCA DPP through NextGen and get feedback from the Y on that. So I think that's it in a nutshell.
Thank you.
Am I the last one? Yes. All right, I promise I'll give you the quick version. Good morning, I'm Dale Brown, I'm Director of the Women's Center here at STAR. And I've been here 22 years and doing work for 40, and I'm hooked. So the Women's Center, underneath that I put community-based, and that's just to clarify that we're not a shelter program. So many people think domestic violence is shelter, but that is not us. So this is sort of an informal mission statement that I'm sharing with you today. We don't have it on our brochures, but really it's to impact change in the community. And this is something that has really emerged. You know, when we first came here, and the Women's Center existed before me, we had the services in the center. And this is what people usually think about when they come. What am I going to get? Counseling or whatever. And we really didn't look at the big picture of public policy, and this is what has changed over the years. To do the work, we need the police, we need all of the community partners. So the core services, again, if somebody comes here, this is what they think they're going to be getting. The individual and the group therapy. And our therapies and all of the work we do here is trauma-informed. But what we know with domestic violence is, and this is sort of a big myth, that once somebody goes to prison, once somebody gets a restraining order, you're done. Oh, you're safe. That is anything but the truth. What we really know is that trauma is about fear, it's about all the other behaviors. So we're trauma-informed. Domestic violence specialist, I'm sorry, I just ran here from a meeting, so I'm still up there. Domestic violence specialist is sort of our triage person. She's worked in the police station, she's worked in courts, and she's really the first person that somebody sees. We don't advertise crisis walking services, but when people are ready, they do knock on the door and they do come in. So she will look at, sit down, do a screen with them, see exactly what it is they need, and put those services in place. Safe Plan advocates are in Fall River Probate Court, which is the old Durfee High School, on Rock Street, and Fall River District Court. Those two advocates, which are funded by Violence Against Women money, will do restraining orders and harassment orders for clients. And I don't want to make an excuse, but we usually do very gender-specific pronouns when we're talking about this work, even though we do see men and we do provide services for them. But statistically, we know that the victims are female. Domestic violence civilian police advocate in the Fall River Police Department, that is something I want to spend a minute on. So have any of you heard of our police advocate? I'm hoping you have. Okay. Is Sam Sutter still here? No. But our civilian police advocate, we had hoped years ago when Bonnie Frank was helping us do this work to get a domestic violence unit in the police department. And we finally got it about 2 years ago through this Department of Justice grant. And what that has done is really change the culture in the police department. Our catchment area is Freetown, Somerset, Swansea, Westport, and Fall River. This position is in Fall River. And what she does, just to give you a little walkthrough, is she goes in the morning, Monday morning, any day she works, she goes through all of the police reports, and she will talk to the police officers. Chief Racine is so on board, goes through all the reports, see if the report is accurate, calls the client, works with the DA's office, works with Batter's program, works with prosecutors, victim witness assistants, people in the DA's office, and with us. So it's, you know, we used to get women who would come in here who would never go to the police department, and we would say, what did the police department say? I'm not going there. What they feel now is that they have an ally in the police department, so that has worked really great. And what we've also done with that is a lot of community engagement. We have something called the Mary Poppins Project. We have distributed with the police over 250 pocketbooks. This is just kind of a fun thing, which you don't think about with domestic violence. 250 pocketbooks in the police cars themselves with this advocate, going to the camps in town, going to shelters, working with women who present in the police station overnight, with supplies, with toiletries, with whatever. So it's really less about the toiletries and more about the connection with the police department. We also provide clinical supervision, Dan's already spoken, I think, for the Batterers Intervention Program. And we have babysitting, which is not a small service, because one of the barriers for women is I can't get services, I have nobody to watch the kids. So those are the core services, and I think what's going to make more sense is if I walk you through a 1-minute thing of if a woman calls. So we have a 24-hour hotline. I happen to be the person on the hotline. And we have a crisis team in the community, and that number is also going to go to me. So let's say I get that call, and you know it's going to be 1:30 on a Saturday morning. And the woman is either in the hospital, the police station, or calling from home. I'm going to get the call, and it's an empowerment program, so I can always think when I hear the story, you better go to a shelter. One of the myths about domestic violence is very few women really go to shelter. And I'm telling you, if you ever have had to try to access a shelter, it's very difficult. Women, they're full. Women don't leave shelters because of the lack of affordable housing. So shelter's not always the first thing, although that's the first thing that a nurse or a police officer may say. So we'll talk about what else could you do. Well, he might be out on the street and we can't find him. And so we call either myself, the civilian police advocate, the great police force now that's really on board. If they can't find him, what we can do is arrange for her to have an on-call judge. There's always a judge, 24/7, that can give her an emergency order. Friday night, Saturday night, that's good until Monday. Now, these are the things she may not know. We can hook her up with a safety and advocate, one of the two advocates in court, and she can get a restraining order. And judges are usually pretty good if she's in fear about that. Then she says, okay, but you know what? I think I really do want to go to a shelter. If a shelter is not available, we're going to put her in a motel or a hotel for a little bit. Not the best way to do it because we don't always have the services there. But one of the problems, too, I want to say with the shelter if we did call and we could access the shelter, the problem is, it's probably in Chicopee. And we don't always necessarily want to leave if they're working or if they have children and the children are in school. So, you know, again, shelter may not work for that reason. So we say, why don't you come into STAR, we'll talk with you. Either the domestic violence specialist or one of the therapists will talk with her. And the things that people don't know that we have to be on board with public policy changes is right now, maybe housing said, you know what, we don't want that riffraff here, we want to be evicted. There are housing laws which protect victims of domestic violence. Or she says, I'm going to lose my job. You know, I can't keep taking time off of work. I've been in the hospital, I've been going to school, I need counseling, DCF is referring me to counseling. There are laws that say, and we've gone to human service departments of agencies, laws that say if you're a victim of domestic violence, you get 14 days per calendar year to get those services, to get medical, to get counseling, to do anything in the court process. So we can offer that. You know, it's a crime, domestic violence is a crime. So then we work with the DA's office, a wonderful domestic violence unit there, and victim witness advocates. And then we find out through maybe our police advocate that this guy, died, but not always, has a long record, what we call a BOP. We look at that, we say, you know what, this is what we call a serial batterer. And we have a high-risk team. We actually started it here at STAR. It's convened now with the DA's office. But we look at what are the risks for her? What is the chance that there's some sort of lethality issue here? Is she being stalked? It's not always just the physical violence. And so the high-risk team, and we're a member of it, we are, Dan is, probation, police departments. So we look at the danger, and we look at, is this person a serial batterer? How many restraining orders have been violated? How many times has he been referred to a batterers program and maybe didn't go? So it's almost a meeting like a Cagney and Lacey kind of thing. Everybody looks at it, pick them up, you know, and then justice is served a little bit better and quicker. So then all the other services, we work very closely with DCF, and one of the things that I did years ago, I was from Judge Baker's Center, was looking at policies and service plans with DCF and how they were leaning towards being punitive towards the victims of domestic violence, who did the right thing, who called and tried to get out of the situation. So clinical trainings in the community, usually with that trauma-informed piece, but on domestic violence, and we've provided trainings for hospitals, for health cures, for a lot of schools, daycare centers on the effects of children who witness domestic violence. We have had grants, we don't right now, but very good collaborations with Bristol Elder, and Elder seems younger as I age out of this all the time, so we had a wonderful, not that it was a good situation, but a wonderful resolution with an elderly man that was referred to us from Bristol Elder. U.S. Department of Justice grant with South Coast Legal Services right now, and that grant provides civil support, not criminal, but civil for victims of domestic violence. So that would include visitation, child support, housing issues. And they meet here. They come here once a month. Again, barriers is sometimes transportation. They come here once a month, and they will provide full services for, they've never turned anyone away, so it's not like it's got a cap on it. I write a column for the Fall River Herald News. I've been doing that for years in the Community Voices section, which runs every 6 weeks for my articles, and again, they're all about domestic violence or some variation out there. We have a new outreach person. She's also the person who we share with the police department. She's not quite full-time there. She's 9 hours for community outreach, and she's been doing a great job in the senior centers, neighborhood associations, worked with Alan Sylvia to get 200 pair of socks to put into our pocketbooks for those things. So there's so many pieces to it that the community, I think, finally is looking at. if they don't need the direct services, but looking at us as an agency that's really helping in the community. And again, the new legislative initiatives I was talking about, housing laws and employment laws, those came right after the whole Jerry Remy case. There's always a rush to new legislation, and so we have to keep abreast to that. And we're also part of the local and area and statewide coalitions that really guide policy. Our funding mostly comes from the Department of Children and Families, but we're not linked to them in any other way, except helping them on their multidisciplinary teams, looking at difficult cases. Most of the cases seem to be opened up for substance abuse, neglect, and domestic violence. So we're a part of that, again, as well as policy. Mass Office of Victim Assistance, those are just our funders. Private donations, we just got 2 this year from obituaries. People asking if they could put in to donate to us, and then we just got a donation from a biker gang, which was very diverse for us. Statistically, 3,046 units, which seems really high if you can retain some of the stats from the other programs. What is not captured in there, though, is really the amount of time and the diverse resources that we're able to provide for women. So and their children. We don't work with children directly, but we figure helping mom, helping dads in the batter's program certainly leads into helping the children. But we were looking at statistics, and 14 months is the average stay that any one woman comes and gets our services. So it's not an event, domestic violence happens and we help her and we give her ACE services. It's really that relationship and that continuum, I think, that keeps her safe. So those are our stats, broken down a little bit, but just know that it's a big, big program. And we've done other things with women that are a little bit creative. We do mask groups. We've published a book on masks. There's a copy at the Vatican, if that's interesting to anybody. We had a nun who's a volunteer, but it's in the Library of Congress, in the Florida Library. And we've had art shows with women, presenting that. So when we look at an empowerment program, it's great for therapy, it's great to get restraining orders, but it's really helping women, go through life in a more empowered way. Any questions?
So we only ran an hour over time. And I know people have to go. We do have lunch. What I'm thinking of is that at the next board meeting, we are going to have our panel that we were going to have today, which will go through a case that has touched many of the programs that you talked today. And there is no organization in this country that really does as much as we do and whose patients have as many resources. And then after that, I'll talk a little bit about the future and where we hope to go, and we'll do that in the next board meeting. For those board members that can stay, we have lunch in the next room. Please stay and talk to some of our staff. They'd love to talk with you, and thank you for being so attentive. So it's going to be the lunches in the boardroom. So